Oops. Okay, good morning everybody. Lights are going down. Thank you. Good morning. My name is Dr. Robin Miller from the University of Birmingham in the UK, and I'm also one of the co-editors-in-chief of the International Journal of Integrated Care. And it's my pleasure to welcome you to this first session of the conference. San Sebastian is looking beautiful despite the rain, and I come from Glasgow in Scotland, where we also have many sandstone buildings and lots of wet weather. So I'm feeling very at home already. It's a great way to start the conference. We know that primary care is absolutely key if we're going to support people in a more patient-centric manner and to be preventative, not just responsive, in how we support people with their health and care needs. So it's great this first session is focusing on primary care, and we have 4 excellent speakers. It's equal measures from the Netherlands and from Belgium. We have 2 each in terms of speakers. But we're going to start off with Sana from Rotterdam, who's going to be talking about patient-centric care. So come forward, Sana.
Welcome everyone. My name is Sanne Kuipers and I'm a PhD candidate from the Erasmus School of Health Policy and Management in Rotterdam, the Netherlands. I'm working on a project on patient-centered care in a primary care setting and specifically for patients with multimorbidity. And today I would like to present you the importance of patient-centered care and co-creation of care for satisfaction with care and physical and social well-being of patients with multimorbidity in the primary care setting. So let's start with an introduction of the multimorbidity patients. Multimorbidity is the presence of 2 or more chronic conditions in one patient. And the prevalence of multimorbidity has grown tremendously, and it's actually expected to increase even further in the near future. And this increase poses a challenge. This type of patient has complex care needs, and therefore it's often difficult and also costly to manage good health care. Healthcare professionals are currently working with single disease-oriented guidelines, and well, as you can imagine, it does not adequately fit the needs of the patient with multimorbidity and their combinations of complex care needs. So we can argue that current care delivery is not tailored to the needs of patients with multimorbidity. And that is a problem, since the burden of multimorbidity is often related to adverse outcomes, leading to a greater mortality risk and an increase of healthcare utilization and cost. And as a result, patients with multimorbidity report lower well-being, quality of life, and satisfaction with care. And within the coming 15 minutes, I would like to argue that making care more patient-centered may be the way forward. So let's start. So what is patient-centered care? Patient-centered care is care that is respectful to and responsive to the individual patient preferences and their values and their needs, and ensuring that the patient values and needs guide all clinical decisions. There are 8 dimensions of patient-centered care. So we start with the patient preferences, which is of course taking into account the patient preferences and values. The other dimension is information and education, and that is informing the patient on all aspects of his or her care. But you can imagine that this information should also be on all levels of the patient. So if you're low educated, you should get the right information to your education level. Coordination of care is how you coordinate care within your practice, so within the primary care practice. Emotional support, you can imagine that having multiple chronic conditions, it also has an influence on your emotional status. So offering the right support on the emotional level is important as well. Then we have physical comfort, that's all about the absence of pain. Involving family and friends is also very important. You're not on your own. Continuity and transition is really about how you, well, coordinate the care with other healthcare providers outside your practice. Access to care is, well, care should be accessible to everyone. So that is from, well, on the one side that you can really access the building. So if you're in a wheelchair, you can access the building, but also that care is financially accessible. And a systematic review found that when organizations work more patient-centered, they also have more positive outcomes. So, for example, a greater satisfaction with care, a greater job satisfaction among healthcare professionals, but also an increased quality of life and well-being for patients. However, most of these studies were only conducted in hospital settings, and they were not specifically targeted to patients with multimorbidity. In addition to the 8 dimensions of patient-centered care that tell us how patient-centered organizations are, it's also very important to examine co-creation of care. This is based on the quality of relationships, and it is characterized by patient-centered communication and interaction. And this is also very important to improve outcomes. So co-creation of care is the establishment of productive interactions between patients and their healthcare professionals. Co-creation of care is especially important in situations with complex tasks, uncertainties, and time constraints. And in this sense, co-creation of care is potentially very valuable for patients with multimorbidity, since it is complex to manage care for this patient type. There are often difficulties and uncertainties in finding the right type of care that is adequately responsive to their needs. And GPs often report that providing care to patients with multimorbidity is often time-consuming. So in this sense, co-creation of care is potentially valuable for providing good care to patients with multimorbidity. And that leads us to the study aim. What is the relation among patient-centered care, co-creation of care, satisfaction with care, and physical and social well-being of patients with multimorbidity in a primary care setting? So, we conducted a cross-sectional study among 8 primary care practices in North Brabant, the Netherlands. All patients with 2 or more registered chronic conditions were eligible to participate. The questionnaires consisted of several validated instruments and were sent by mail. And in total, 216 patients filled out the questionnaire and consented to participate. And this led to a response rate of 55%, which is actually quite high given the vulnerable status of this patient population and compared to other studies. I have to say that the practices that were in the study were actually quite enthusiastic practices, and they are leading in their patient-centeredness compared to other practices in the Netherlands. So this table displays the background characteristics of the patient. And if you take a look at the red outlined boxes, you can see that it concerns a very vulnerable patient group. So the mean age was 74 years old, and almost 40% was low educated, which really means that they only have a primary school and no further education. And 43% was single, which only adds up to the vulnerable status. The average evaluation of the patient-centered care of these primary care practices is 3.84 out of 5, which actually means that these practices are performing pretty well on patient-centered care. But there are two dimensions which score lower compared to the others, and that is emotional support and family and friends. And if you look at the lower red box, you can see that patients with multimorbidity often evaluate their relationship with their GP as higher compared to the specialist and nurse practitioner. Here you can see the results of the multivariate analysis. So after controlling for background characteristics, patient-centered care was associated with satisfaction with care, social well-being, and physical well-being. And co-creation of care was associated with social well-being and satisfaction with care. And although we found a significant association in the bivariate analysis between co-creation of care and physical well-being, this effect dissipated in the multivariate analysis. But as you can imagine, if you are in pain or your physical comfort is low because of the multiple diseases, you can imagine that when you have a very good relationship with, for example, your GP, that, well, maybe helps for your social well-being, but not, it cannot take away the pain, so it doesn't add anything above the And why we choose this in primary care, because I think that's very important for patients with multimorbidity. They often see their nurse practitioner and general practitioner, and that's also, yeah, I think a lot of studies were already conducted in, well, hospital settings, and this was missing, and I think actually it's a very important next step. So that's why we choose for the primary care.
Well answered. Any other questions? Yeah. Just wait for the microphone.
Hello, thank you. I'm Gunther Danis from the Flemish General Practitioners, Belgium. Thank you for presentation. Co-creation is about two parties. You got patients, patient-centered, but also professional caregivers. And in patient-centered care and co-creation, they both have to have satisfaction. Do you also measure the satisfaction of the professional caregivers, the doctors and the nurses and the physiotherapists in all those situations?
Yes, we did. We also have the data of the same questions, the same questionnaires among the healthcare professionals, but we have not analyzed them yet. So that's for next time, but yeah, we did.
So you'll have to come back next year. Okay, great. Well, thank you again. That was an excellent start today. Thank you very much.
Thank you.
Okay, so now we've got Lisbeth from Belgium and from Antwerp, and who's going to be talking about health and vulnerabilities and development of care guidance. And I should say we're very into tweeting in the conference, so do take pictures, do write comments online, let's get some good discussions going right from the off.
Continue talking. You hear it through the microphone? Yeah? Okay, thank you. Good morning. I'm Lisbeth Meijers from the city of Antwerp. I work at the health department there, and I focus on primary care there. In my job, I support the establishment and organization of general practitioners, and I encourage the cooperation between the welfare and the health sector. Yeah, and I wanted to talk to you about, today I want to talk to you about creating a care guideline for general practitioners. As a local government, we like to support general practices in connecting with welfare. But first I'd like to take you to Belgium, to our healthcare system, and we see there a big change in the primary care. For starters, the general practitioner in Belgium is a manager of healthcare, more and more, we see them like that. And also we see an evolution in socialization of care. I found it a very difficult word, socialization of care. So, the socialization of care, so more the importance of family, the community, that's an evolution that we see. And as a local government, we also have to take account the higher authorities, our higher authorities, like the federal government, so Belgium, that regulates the health costs, and then the Flemish government that regulates the organization of the primary care. And last year, the Flemish government started with the primary care zones that has to stimulate the collaboration between health, welfare, the local governments and informal care organizations. Yeah, that's basically what the goal is. To have a notice about the scale, in Antwerp there are 4 zones each for about 120,000 inhabitants. So that's those zones. And in this primary care, we see also the patient as a director of his health. And then in Antwerp, our big city, we think it's a really nice story, a really good evolution, but we also see some challenges, but it's a really nice story. So we can support it, but in our city, we see also that we have various neighborhoods, like you see those really dark neighborhoods. you see that there are like 40% people with a low socioeconomic status, so that's really high. So when general practitioners has to give care to those people, it would be a little bit harder. So we wanted to give them extra support. Because as we know, health inequality follows the socioeconomic status and sometimes also ethnicity. So that's another thing that we see in the city of Antwerp. We have in some areas also like above 70% inhabitants with another ethnic origin than the Belgian one. So those are two major challenges in our city. So as a city we thought, okay, we have to create this care guideline for those vulnerable people to support the general practitioners. So why do we do this? When we see at the medical care protocols, we see that they are not always feasible for vulnerable groups. There are many barriers. For example, when we see at the medical care protocol for diabetes, we have the doctors, the GPs have to promote a healthy lifestyle, taking daily medication, follow up by various specialists, arrange administration to obtain additional allowances. There are many things you have to do, and when you're vulnerable, there are a lot of barriers to the healthy lifestyle. You can't buy the healthy food, you don't have the knowledge about healthy food. There are really many barriers. And in the city, we also like an equal health opportunity for every citizen. And also why we also do it is because diabetes is an important medical problem, of course, and is strongly present also in people with low socioeconomic status. And the last part why we are doing this is because there's no common language or agreements between the health and the welfare sector. So what do? We add a social nurse in each GP's practice. Not in each, but still growing. We have 5 social nurses for the moment. There will be 6 really soon. And what do? They follow up the vulnerable patients, so individually, and they support the GP to have a well-organized electronic medical record. I don't know the ICPC codes, how it is in other countries, but in Belgium it's support for the GPs to code medically. It's a code by the World Health Organization, so they can code the medical problems. What does the social nurse do? Besides that, she started the formalization of agreements with other primary care actors like the welfare sector, home nursing or home help. Our goal is that the health of vulnerable chronically ill patients in the first phase with diabetes is better monitored, and the GPs are supported by a network of health and welfare actors to achieve this. The social nurses, what do? In the first phase? That's the patient level they work in. That is identify the patient group, so make a list of all diabetes patients in the practice. They filter out the patients with a more permanent HbA1c value above 7, so the patients with diabetes and the value is not really good in control. And start to follow up those with elevated values. So the most vulnerable patients, patients with a bad adherence. And then they identify which problem other than medical could be the cause of the increased values, so the risk factors. We are going to search for the risk factors. In more basically words, are there any other medical problems that stand in the way of good blood values? For example, perhaps there are financial problems, so they are not buying the proper medication. That's just an example. In the second phase, we talk not about patient level, but about the GP's level. So the risk factors are appointed, and then we start a collaboration for the more common problems, the risk factors, with other organizations, and we implement this collaboration tailored to each general practice. What are our challenges? We have to see that the communication is going well between medical and non-medical professionals, because that's really not really easy. And the next thing we saw is, how does the GP know that someone is vulnerable? That's a question that really came a lot to us, and we had to search for a method about that. And there was one condition: it must be in line with the diagnosis treatment thinking of general practitioners. We see that GPs more think like there's a diagnosis, and there's a diagnosis and that's a treatment. But when we see at the welfare organization, it's more a process. They think in processes. So it has to match both worlds. So then I was really glad that we found out that there were ICPC codes, not only for medical problems, but also for social problems. And the social codes, we found out there are social codes. And examples of that, like the social code 1 is financial problems. The social code 4 is problems with social cultural adaptation, for example, the language. Like number 7 is problem with training, and it possibly there is possibly a limited health skill by the patient, or like 29, dependence on others. So we saw those social codes as an indicator for a risk factor, and we can put it in an electronic medical file, so we can charge it also in the summary. This is a summary of medical file to be forwarded also to other disciplines. So it can be marked as a risk factor, and the other person who also sees the patients is informed that there is a risk factor. And how we see it is also the social code as a basis for collaboration, the start of a collaboration. This is, I don't know, it's okay. I thought it was really small, but it's okay. So this is a scheme, how we see it concrete. So above you see the diabetes with the HbA1c above 7%. Then in first phase, the social nurse is going to support the GP to identify those problems, but in a later phase they have to do it themselves. So we see then when you have a high HbA1c
el nivel del HbA1c.
Health skills, and then we start the collaboration with the home nurse, who can explain the situation again, the illness again, and maybe in the same language as the patient. So that our collaboration that we are starting. Another interesting thing is the financial problem. Then we start a collaboration with the social services of the Public Health Insurance Fund, because there might be an extra financial support the patient doesn't know about. So these are the really, the collaboration we start up. It's a social nurse who does it. The social nurses are really the big thing here. They are doing all the work because they have to make the collaborations work. Another interesting code is the 29, dependence on others. And then we start collaboration with home health, because they can do a lot. For example, when a patient goes to a dietist, he gets the information one time, but how does he implement it in his daily life? That's a really big step, certainly for persons with a vulnerability. But they can support those people and prepare a healthy meal. I forgot the word meal, but it's meal. So they can prepare a healthy meal and maybe do the groceries together or follow up the administration, go to the specialist together. So it's a really good collaboration, and I think it's. I expect a lot about of this collaboration. So that are a little bit. The things how we see this and how we do it. Now we started last year in March, so it's not really that we have a lot of experience, but the first conclusions are like this. By being present in a general practice, we can implement the cooperation with welfare actors in the existing systems and in the daily functioning of the general practice. So it's not only the theory that Flanders give us, it's really the daily functioning that we're going to change. The presence in the general practice of someone with knowledge about both welfare organizations and medical language is clearly an added value. And also the return for welfare actors, the cooperation with someone with knowledge of medical language is a clear added value for the guidance of their client. And the most important, I think, is the clear division of roles. There's no extra work created, but each actor has a clearly defined task that is also clear to the other actors. Because we see this in like the medical world, we see the GP knows what he has to do, the specialist knows what he has to do, and they know it from each other, but when they see at the welfare sector, it's really buzz. It's like, ooh, what is it, the welfare sector? Ooh, it's, I don't know, it's, ooh, what do they do? And I don't know what they're doing. So it's, yeah, we have to, give a clear vision of what they are doing. So, other first lessons learned, we see that the patient feels more supported in coping with his illness. Also, the connection with the diagnosis treatment thinking of general practitioners to make the collaboration with the welfare sector work. It's really important. And we have to work tailored to each general practice. So we don't have to say, this is the model, do it like this. No, it's a little bit see how it's working with each GP. We have to use also the software the GP uses to complete the medical file with more contextual information, so not sending an email with this is a report, I saw this client. No, it has to connect with the medical file and directly connect with it and not being extra work. And we have to connect also with other projects, like in function of prevention, for example. The sustainability, I have 2 slides, and only one of actually. This project requires an investment cost, of course, that the city is doing this, with the temporary staff expenses for the nurses. So it's the temporary thing we do at the GPs. So now it's 1 nurse per GP practice, for 4 months, maybe 4 months per GP. So when it's a group practice, they can be there for several months, but when it's only 1 GP, it's only 4 months. But the expectation is that we are going to have an evolution from being present in the GP's practice to attend at neighborhood level. So 1 nurse per neighborhood, that's our goal. And what does she have to do, the social nurse? That is the coordination of those cooperation agreements, start new collaboration, or there might be a follow-up for highly vulnerable patients that might be necessary. And for finishing, I finish with this really good cartoon from last year. I saw it last year in this conference. The hard part was pulling my head off the wall and reattaching it to my body. And I think that's the integrated care is what's all about. So, okay, thank you for the presentation.
Okay, thank you very much. So I'll go for questions from the audience, but can I ask a quick question first?
Yes, yeah.
So were they qualified nurses? And did they have particular training to help them to understand the welfare services that were there?
No, they were already welfare. No, they were already, how do you call it? A social worker. Yeah, okay. They were social worker, but they have they are nurses. So in Belgium, you can study social nurse. So it's a profession. Okay. But now
so they're duly qualified as a nurse and a social worker.
Yeah,
wow.
Yeah, they are the both. Yeah.
Impressive.
Yeah.
Okay, thank you. Great. Okay, any questions? We've got 5 minutes.
Yeah.
Oh, yeah, one down here. Great. Sorry, I didn't see you there. Microphone coming. Thank you. And do say who you are.
Thank you for your nice presentation. I'm a GP from Holland, Lia van der Vorm. I wonder, why did you focus on diabetes only?
Oh, it's also because we thought when we come to the GP's office and say, oh, we wanted to support you for welfare, it would be not concrete enough. So we do it for diabetes. We are working on a care guideline for diabetes, but we see also other patients. When the GP says, I have a problem with this patient, I don't know what it is, we also do the guidance of that patient, but we are now working to a care guideline for diabetes, but we do also other patients.
Okay, then I have another question. Did you see any influence on the diabetes, the regulation?
Not yet. We have to. We just started and it's a work in progress. So we started from now on with the search and together with the university to see if it's working.
For next year?
Yeah,
for next year. Yeah, part two again. Okay, anyone very quick, time for one quick question? Yeah, over there.
Thank you for your presentation. My name is Therese. I'm also from Belgium. I'm from UCL. I have a question about how does this match, in your view, with the previous presentation? How does it fit with the life goals of the patients? And my question is very precise because when you showed the slide with the 4 Z codes, many other determinants of the quality of life with the disease influence the adhesion to treatment, etc., and are not there.
Yeah,
and how are you going to cope with that? For instance, how do I cope with my illness and my treatments while I'm working? It doesn't not fit any of those boxes.
No, but there are, I only showed 4 codes, but there are 29, and one of it is coping with the illness, and then we start a cooperation with somebody else, so another organization. But when we see those vulnerable groups, we see more problems in the financial things or the lifestyle or the independence. They have a problem with independency. So that are the most they have the more priority at the moment for the vulnerable groups. But we see also the other things.
The list is not exhaustive. That was my question.
What?
The list is not exhaustive of the codes.
No, there are 29, and I hope everyone who's GP uses or is going to use those other codes than medical codes, because it's really good to have an idea. What other problems can there be than the medical? But there are more codes. Yeah, okay. 29.
Great, thank you. I was thinking that I was going to ask that question as well, so that's a great question to ask. Okay, so thank you very much, Lisbeth. Great. Okay, so now we're off to Brussels with Marlene, is going to tell us more about joint working between home nurses and general practice. I had the pleasure of being an external examiner on Marlene's PhD at the end of last year, and it's a fantastic study. So if you want to know more about acute care and general practice working together, do catch her at the break. Okay, over to you.
Good morning, everyone. Well, as Dr. Miller said, I'm also from Belgium, but I'm from Brussels, and I have the pleasure to be presenting the results of an inter-university project, actually, which took place in the French-speaking regions of Belgium about interprofessional collaboration between GPs and home nurses. It was it was initiated by regional authorities because they have recognized the need to enhance interprofessional collaboration between GPs and nurses, given the many challenges facing primary care level currently in Belgium. So let's talk about these challenges.
To start with, the Belgian population is very aging. As you can see, the percentage of Belgian population whose age over 65 and over 80 are a bit higher than the OECD averages. The Belgian population is also suffering from chronic diseases. And the cost of the Belgian healthcare system is also a bit higher than the EU 15 countries. And areas where saving could be made are mainly related to long hospital stays, which has led to a move toward community-based healthcare and early discharges home, which is expected to put further strain on the primary care level. Another characteristic of the primary care level is about the GP shortage and the uneven distribution of GPs across the country. The density limit that was fixed at a national level was fixed actually at 0.9 GP per 1,000 inhabitants. And when we look at these figures, we could clearly confirm this shortage in rural Wallonia, which is the French-speaking region of Belgium, and in lots of urban areas also of Wallonia. This shortage is expected to be much more problematic in few years because of the aging population of GPs on the one hand and the limited attractiveness of GP for young doctors on the other hand. So basically, these GPs are approaching retirement age without having sufficient recruit to replace them. The same goes for the nursing profession. Nursing workforce is also aging and is also unequally distributed across the country. When you look at this table, you could clearly see that only 27% of the total active nurses in Belgium work in Wallonia. And the big majority of these nurses work in hospitals, and only 7.4% work in home care, which is clearly not sufficient to be able to face the challenges of aging population, high prevalence of chronic diseases, and this move toward community-based healthcare. And one last characteristic is about the heterogeneity of practices and organization and financial mode of both professions. So both GPs and nurses have the possibility to be working either in solo practices or monodisciplinary group practice or multidisciplinary group practice, or eventually within an integrated health centers, although integrated health centers, also known as community health centers, are still slowly developing. And they also have different payment systems, as you can see here. So consequently, collaborative practices between GPs and nurses varies on a continuum where solo and independent practices of both professions represent a full segregation and with almost no communication actually between the two professions, and we move progressively towards a full integration within the community health centers with shared patient population, shared health records, pooled resources, shared spaces, etc. What we know about interprofessional collaboration is that it increases a system capacity and it gives a means to professionals to achieve more than they can do on their own with less time, less resources, and better outcomes. So interprofessional collaboration seemed of particular importance for us for this context. And given these characteristics, the objective of this inter-university project was to assess interprofessional collaboration between GPs and nurses in different areas in Wallonia, and then to identify target priorities for each of these areas for improving collaboration and endorsing participants' improvement project. We used a bottom-up approach, starting with the pre-operational phase, establishing a diagnosis, consulting the literature, choosing a conceptual model to guide the total approach, and then moving to operational phase, which is actually very similar to a PDCA cycle: planning, action taking, evaluation, reflection and learning, and start over. 6 areas participated to this project. We aimed for a diversity of practices, of payment system, Also of human resources, as you could see on the GP density row, and environment. We had both rural and urban areas, and 2 areas had a very low socioeconomic status. And in accordance with our objective, we started by establishing a SWOT analysis of the 6 areas, and we have classified them according to the Reeves conceptual model of teamwork. Then each group choose a priority, an action to be planned and implemented within their area. Despite the heterogeneity of practices and of priorities, 2 issues were identified as common for the 6 areas, and they were studied more in depth. And finally, researchers, we as a research team, we met with each area on a monthly basis, and we also organized meetings between participants so they can exchange experiences, and with participants and the steering committee. So I will start by explaining the combined result of the 6 areas of their SWOT using, according to the 4 domains of Reeves' model of teamwork, which are about processes, context, organizational, and relational domains. Strength in relations with related to relational components were mainly about the fact that professionals, donc GPs and nurses, shared power and shared responsibilities. The fact that they knew and they trusted each other, and that they have had previous experiences of collaboration, but also the fact that each of them recognized and respected the other's competency and specific role. The small size of a team was also identified as a strength because of what it allows in terms of informational communication and enhanced relationship, and because also it facilitated sharing values. As I said before, collaborative practices varies on this continuum. So on the other hand, we had also participants who said that they had lots of weaknesses, such as hierarchical relations that impeded innovation and initiatives within a group, lack of trust, of consideration, and of responsibility clarification. We have no idea who is supposed to do what. Concerning processes, main strengths were related to the fact that they shared procedures and they shared also clinical guidelines with, again, clear description of who is supposed to do what. Having effective communication tools, whether coordination notebook, a simple coordination notebook that can remain at a patient home, or emails, or even shared electronic health record. Regular meetings were also considered as an effective communication tool. Shared spaces, because they allowed informal communication. And also one last strength was about the task characteristics. They really appreciated when they had an alert system that enabled them to react and mainly to interact in case of emergencies if the task is urgent, is unpredictable, or is complicated. The fact that they didn't share a patient population, lack of shared patient's population, they didn't care for the same patient. It was very difficult for them to identify who is the regular GP, who is the regular RN, nurse, who is taking care of this patient, was a main weakness for them. And it also created informational discontinuity. And also the fact that they didn't have enough time to be dedicated for consultation and coordination and communication was identified as a major weakness. Opportunities related to organizational support were mainly about the allocated human and material resources. Do we have a secretary who could take care of time-consuming administrative tasks? Do we have spaces so we could meet and discuss issues related to our collaboration, etc.? On a more meso level, professional association of both GPs and nurses provided them access to clinical guidelines and provided them access to continuing education based on their own needs, tailored needs actually, and this was considered as a major opportunity. On the other hand, heavy workload was a major threat. And finally, opportunities related to the macro environment, to a more macro context, were about the capitation payment system that inhibits competition between GPs and nurses, and that allows them to dedicate more time for team meetings, actually. Also the fact that there is a clear political will to make more professions more attractive and to create and to find new modes and models of collaboration in order to tackle the challenge of shortage, which I have talked about earlier. Unfortunately, there is still a lot to be done. We have few integration strategy. There's a lack of clear vision of what is the primary role of a primary care, what is its mission. There's a lack of classification of some existing nursing acts, meaning that the nurses do lots of tasks on a daily basis and are not recognized for them, are not paid for them. For example, patient education, which raises the question of who is supposed to do that? Why do I have to do that if I am not paid for that? Isn't it the GP's job, which again creates a task clarification problem? And we don't have a nursing order that defends nurses' benefits. The second phase of this project was about identifying a priority for each area to be planned and implemented within this area. Unfortunately, we do not have the time to go over every and each action, but as you can see here, they all revolve around two common issues, which are communication and task delegation. So these two issues were studied more in depth. We conducted a survey among professionals. We also conducted qualitative interviews and experts consultation. The results showed that communication could be supported locally. Participants could improve their communication by improving their use of the existent communication tool at their disposal, and also by dedicating time for multidisciplinary team meetings. However, two issues need to be taken into consideration, which are involving the patient in communication. They need to better involve the patient in communication and protecting patient health information. Lots of GPs and lots of nurses uses WhatsApp to send pictures of, let's say, infected ones, which is really not secure, and they underuse the existent, more secure information and data sharing system. So on a more macro level, recommendations include promotion of this existent information sharing system, facilitating the transition from paper to the use of IT, creating opportunities for communication and multidisciplinary coordination and consultation, mainly by allocating adequate resources, and promoting multidisciplinary group practice. What we found, one major result was that actually GPs and nurses working within a group practice felt like a team and have developed a team identity. They have shared spaces, shared resources, they met on a daily basis, had informal communication, and eventually became a team. Okay. Task delegation was also found much more challenging issue to address and raised question about the nursing skills, the continuing education, the legislation, the capitation payment system, etc. So our recommendation include, again, promoting and supporting group practice because they were found to facilitate task delegation, establishing care pathways for chronic patients within the primary care level with a clear description of who is supposed to do what, at what moment, with what resources. And if we need to move towards this task delegation, we need to make sure that nurses have the necessary skills and competencies in order to do so. We also need to reward their intellectual tasks, such as patient education and many other, establishing a nursing diagnosis, etc. Facilitating task delegation from nurses to nurse aides, so we could allocate more time for nurses to be doing much complex tasks, and finally, reviewing the legislation and allowing this legislation to allow role expansion. Well, in conclusion, we know that interprofessional collaboration has lots of benefits on a patient level, on professional level, on a system level, but implementation of collaborative intervention is still very complex because it depends on the interaction between macro and meso and micro factors, both governmental and local factors. What we found is that it's even more challenging when GPs and nurses do not share the population, and do not have effective communication tools. And finally, we have talked about task delegation and the fact that it is very challenging. What we still need to address, what we still need to explore is about patients' acceptance of this task delegation, and this is a whole new domain to be explored in the future. Thank you for your attention.
Okay, fantastic. So, any questions or comments? Scan the audience together. What was it? It was very clear, exactly. It was such a clear presentation, you got no more questions. Excellent. And what would be your priority recommendation then, in terms of trying to improve the collaboration between the nurses and general practice? So if there's one thing you think would make a difference, what would that be?
I think it would be communication and mutual acquaintanceship. They need to get to know each other and to better communicate with each other, which is the central key of everything else, I think.
Yeah, fantastic. Because then you can overcome a lack of protocol, delegate tasks because you understand each other.
Yeah, but also because you could negotiate when things are a bit complicated, and you could interact and come to a shared decision making.
Okay, fantastic. Okay, great. Thank you very much, Marlene. Okay, so now we're going back to the Netherlands, Utrecht to be precise, and Semek is going to talk about healthcare professionals working together. Fantastic. Do you want to say a little bit about who you are? Yes. Okay.
Hi, thanks for being here. I'm Sanneke Schepman. I work as a policy advisor, as a PhD student, and as a teacher. And I like to present here one of my papers of my PhD project. It's about professionals and the role of professionals in collaboration in primary care. But the thing I think that adds to the other presentations, very good presentation by the way, is that my study is more on a sort of different level because it's interorganizational study. So we studied the collaboration between primary care, but sometimes also with hospitals or other like welfare, just as one of the earlier presentations. So the background, interorganizational partnerships, I like to prefer to speak about those interorganizational things. They are increasingly used to tackle complex problems such as multiple morbidity, but also high costs, etc. However, I did systematic literature review and found that most of those collaborations, less than half, they do not generate positive results. So I became to wonder, could it be that professionals are the key to the success of collaboration in the primary care? So this is what my study is about. To what extent does the healthcare professionals' feeling of urgency, involvement, the presence of this and advantages relate to the perceived quality of care according to professionals and the success of the collaboration according to management. So I did the study at 2 levels, the professional and the management level. I looked especially at that last level because if you ask a professional first about their feeling of urgency and then about the success, it might be a little biased. So that's why I also looked at the management. I did a multi-level analysis, and I explained already that that was structured at 2 levels. So the level of the professional nested within the level of the project, and the project, that means interviews with project leaders where we asked about the project success. It was a longitudinal study collected in 69 collaboration projects in Dutch primary care. They all started in 2011 and finished about 4 to 5 years later. Data was collected by interviews with the project leader and 2 project employees and among healthcare professionals that delivered care to the patients. And those professionals were not only GPs, but they could also be a nurse or a midwife or like all kind of different professionals. At the professional level, we looked at the feeling of urgency. We measured it by looking at if they felt that there was a need for the project, but also if they could solve a problem. Then we looked at the involvement. So at what level were they involved at the project? So did they were just a member of the project, or did they also have like an involvement in more steering committee or something like that? And we looked at different disadvantages, such as that there would be more administration because of the project, or advantages that they were, for example, better, more efficient because of the project. And we scaled it up to a group of disadvantages and a group of advantages. And also we asked about the perceived quality of care before the project and after the project. And then at the project leader level, we just asked about the project success at the end of the study. The results. The study shows that a feeling of urgency for the collaboration project among professionals at T1, so at the beginning and at the end, is of influence of a higher perceived quality of care. The involvement did not show any results, and experiencing many disadvantages has a negative impact on the perceived quality of care. So you would expect it, but it also really worked like that. Professionals that were experiencing many advantages show positive results on the perceived quality of care, also really expected. And these effects were bigger than the effects of the disadvantages. There were no significant outcomes related to the success of the project. So the project success did not relate to any of those, unfortunately, any of those indicators. But the project level explained most of the variance, and that could be an indication that management is important. So that's why I think management level and professional level are both important for the outcomes. That's also confirmed by other research on collaboration. But what we found was that professionals were not as involved as they should be in the projects. They were not aware at the beginning, but also not at the end of the project, that they were even in this collaboration project, which was, well, a bit worrying, I thought. And that might be one of the reasons why literature shows only in less than half of the project success. So my conclusion is the use of collaboration as a strategy to improve care in primary care should be decided by managers, but also by professionals, and there should be a kind of feeling of urgency, so they need to stick to what's the problem, and that should be felt by everyone. But also it's good to look at the advantages and the disadvantages. So what's next? It's one of my papers, but the next one is about the role of the patient. And what about trust in a collaboration? Okay, that's it.
Thank you very much, and it's so important that we try to understand what leads to success in such projects. So did you speak to the managers at all about the level of disengagement by the clinicians?
No, unfortunately not.
Okay. Did you feed back results to them? Or?
Well, we did, but I did not.
Okay. Okay, great.
This is a collaboration of many.
Many people, yeah. Okay. So any questions or comments? Oh, lights back on.
Thank you for the presentation again. Maybe one thing was not very clear to me is the unit of analysis. You spoke about 69 collaboration projects involving GP and nurses, but could you be more clear about what is the management to do with this? It was not very clear to me. Can you say something about the structure of those projects?
Actually, it were projects, were all really different projects. So there could be a collaboration of an organization of GPs with midwives, with nurses. We're really different types of projects that we compare to each other. I don't know if that's really answers your question.
Were they all in individual practices, or were they multiple practice levels of the 69 projects?
There were different organizations within one project. So the 69 projects contained of more than one organization. Yeah. That's why I call it inter-organization.
Okay. Yeah. But it's interesting there was such a common experience amongst very different projects and very different organisations. Yeah.
Yes, yes.
Yeah. Okay, another question? Front here.
Good morning, Adriana Martinez from APTES. You just left an open question that's very interesting to us, which is how to build trust in those relationships. Are you already working on it? If you can share with us a little bit how to build trust relationships?
Well, I've worked on it some ages ago, I think. But yeah, so I can share my paper, but I don't really, I can't really remember it right now.
Do you have anything you could share? Because trust is clearly one of those elements that comes up in any collaboration.
I don't know if this is allowed, but I do recommend you to take a look to the Launza poster, which is displayed here at the Congress. We're trying to work on trust, on high mutual trust between different professionals at the neighborhood level, but some of them are here. But it's really something, because trust, it's a matter of spending quality time together. It takes time. The management has to allow to spend that time. The professional, each professional has to identify that a value of that time, of that invested time, is he or she takes it to his daily or her daily work. So we see it as a craftsman or a craftswoman work, building trust, I mean.
And so you're working on the trust of professionals. And what I do is the management level, the steering committees. That's what I look at.
Yeah, no, that's interesting. So can you talk a bit more about that then? Because one of the things you often find in the management layers is that people move on and get new jobs, whereas perhaps often general practitioners, not always, but often stay in the same area for a long time. But in management, there's more of a culture of you start a project, you leave 2 years later, you get a promotion.
That was one of the problems, yes. but it's a little bit long ago when I worked on this paper.
Okay. Well, that's good. So your poster sounds a very good addition to the discussions today. So that was great. Yes. Yes, great. Question at the back there? Okay. Microphone is coming. It means we build up some anticipation for your question. It's like a dramatic prelude.
You might be disappointed. I'm a GP by background, but Director of Integrated Care at the Health Board in Northern Ireland. So there's a growing trend, in fact it's government policy across the 4 nations of the UK, to encourage GPs to work together in networks. On the basis that GP practices being small units, they may lack time capacity, they may not have the leadership skills to build trust. Have you looked at that, the potential for practices to work together in a network, and then the leadership that emerges from that to work with nurses and other professionals?
Well, we do have data on it, yes, but I haven't really looked at it yet.
Okay. Elizabeth, is that something you touched upon? Because you were looking at primary care, let me remind myself, zones of primary care. Was that something that you touched upon in terms of trust between the different primary care practitioners?
Does it work? Yeah. The trust, I think it's not something you install. It's like we see in our project when the social nurses are present in the GP's practice, and they spend time together and they see that what they do it well, that the trust is building itself. So I think we have to learn that it costs time, because sometimes there are like 6 months in a practice and then they start to work together on a good way. Yeah, I don't think there's a magic word for trust, but it takes time, I think.
Marlene, did you want to add something to that?
Yes, if I may add, I have done a systematic literature review about interprofessional collaboration, and as you know, trust is one major component of collaboration, and what the literature says is that trust is built over time when professionals have had positive previous experiences of collaboration, and when they know that in case of emergencies or any other complex situation, they could rely on each other, which actually send us back to trusting in the other's competencies and the other's intentions also. So, which brings us back to the competition. Are we in competition with one another, or do we trust each other that we have the same objectives related to the patient? So the payment system plays again a major role in this trust when resources are sparse, and when we start to fight on resources, this does not help with trust. So one strategy which is known in the literature, again, I haven't done a field work about it, but it was about interprofessional education. When we learn to know about the other's competencies and the other's specific role. So we trust in these competencies and in the complementary role of the others in relation to the patient care.
Yeah, that's exactly what I meant. Yeah, you have to clarify those roles. So what is the other person doing, and they do it well. And we see that it's growing. It's of course easier, I think, when it's perhaps for vulnerable groups and it's a social worker, they know nothing about it. And then certainly the problem is solved, a problem that they know nothing about, and they can do a good guidance of the patient, the GPs then they think, whoa, wow, social nurses are really, they're doing a good job. So yeah, I think what you say is exactly what we have to do. Yeah.
Did you want to add anything from your Northern Ireland experience? Have you lost your microphone? Sorry, yeah.
Well, I mean, I think we've GP federations, so one federation per 100,000 of the population. I think the key thing is that they are owned by the doctors, that they established through their trade union, the British Medical Association. So management can come and go, but you get the consistency of local autonomy, working with management in a collaborative way and working with other professionals in multidisciplinary primary care teams. So, yeah, I mean, that's going pretty well. In England, you have primary care networks now being introduced in Scotland, GP clusters, and Wales is equivalent too. So, I mean, I do think that's the way to go. I think it gives you organisations a bit like Bertzorg, which has had some successes in nursing and domiciliary care in the Netherlands.
But then one of the key issues is how we ensure that general practice doesn't dominate as a profession, because that's one of the downsides, isn't it? When you've got one profession owning and running the network, there's always a danger that other professions feel, as we heard from some of the other speakers, about the hierarchy and the power dynamics. So that's the next step, isn't it? We've got the general practice engaged, great, but how do we make sure that it's open for collaboration and contribution from others?
Exactly. So in Northern Ireland we have integrated care partnerships, and the federations are a subset of each integrated care partnerships with the other professions, including medical specialists, patients and the third sector included with that. So it means a lot of networks, and that has an overhead, but I think it's well worth it.
And I would encourage anybody who doesn't know integrated care in Northern Ireland to go and talk to our contributor today, because it's often the forgotten part of the UK, but actually it's been doing integrated care for a lot longer than many other parts of the UK, so it's good to hear that flagged up. Great, and one more question over here, and that's our last question, I think, so we're going to finish off in a dramatic finale.
Netherlands.
Okay, great.
Because we have, my name is Mark Bruins, and I'm a director of a small but nice knowledge institute, Jan van Nes Institute, about integrated primary healthcare. And what we see in Holland is now that we have those networks of GPs as well, and the payment reform is going after that. So it's not one of the incentives, but the other way around. But what you see is that especially the GPs are dominating those networks, but now we see in the regions where the GPs have a solid network that the other disciplines start to build their own network as well. And because of that, now you see at the regional level that the interdisciplinary or the interprofessional collaboration starts to work there from those different networks. So we think you should, or I think you should in a way, not want to build everything at the local level, interdisciplinary, etc., organizational wise, because then you end up with the dominance and the etc. So try to get it at a little bit higher level, and then for the nurses and for the pharmacists and for the social workers, etc., that they have their own networks as well.
That's really helpful. Thank you. That. Okay, so can we just say thanks to all our presenters today? As you can imagine, it was quite daunting to come into the first session to this massive auditorium, but I think they did a fantastic job, so well done all. And I think we opened some good discussions for future discussions as well. So we have trust, we have patient-centric care, we have organisation, we have the interaction between managers and clinicians, and hopefully over the next 3 days we'll have more time to debate those. So thank you all, enjoy your coffee, enjoy the rest of your day. Thank you.
Well, good morning. Welcome to the session. I'll stop shouting. My name is David Perkins, and I'm the director of the Centre for Rural and Remote Mental Health based in Orange in New South Wales, Australia, and part of the University of Newcastle in Australia. We've got a great session. The session you're at, without a sessional page, is on integrated care and mental health. So if that's where you expect to be, that's where you are. I will keep our introductions to a minimum because we want time to hear our speakers and we want time for questions if we can do that. We have 5 oral papers of 15 minutes and 1 oral poster of 5 minutes, and hopefully we'll have a little bit of time for questions after that. So I'd like to welcome firstly to San Sebastian, Sebastian Rosenberg from Canberra in Australia. Sebastian.
Thank you. David, and I'm delighted to be here. You guys look slightly different with your clothes on. I'm pretty sure I saw some of you at the beach yesterday and you looked a bit different. I also need to have a bit of a disclaimer that I think you are here to find out about integration in mental health care. Well, I am a fraud. I don't know if it's the conference's first fraud for 2019, but I'm here to tell you about disintegration. So I'll go quickly through what I will talk about. I'll give a quick overview of mental health in Australia. I'll talk about the 5th mental health plan. We have 5. You can't have too many plans. We have an introduction to the ACT, which is where I'm from, and our understanding of what we mean by integration. And then I'll quickly, as a model, tell you about what we did. How did we execute our goal of integration? What did we do? What has happened subsequently? And then I want to have a discussion about what does this mean for integrated care in the ACT. And there will be begging at the end where I plead for some assistance, and I'm hoping you can help me. I won't spend very long on this because it's just important to locate things about mental health in Australia. So we know that we have lifted the rate of access to care, which is great. We know that it's about 12% of the burden of disease, but it only gets about 7% of the total health budget. And I think it's fair to say that the overwhelming focus is on hospital-based care still, either as an inpatient or an outpatient over community-based care. Things do vary a little across our jurisdictions, but that's fair enough. And in terms of the budget, it was about 7.4% 10 years ago, and it's about 7.4% now, so nothing's really changed. I think a lot of people in Australia think that things have changed, but I don't think the evidence is strong to support that. And we know that 1 in 5 adults per year will have a mental health problem, and we also know that it's a young person's problem. And I think this is really critical, and you think that 75% of all mental illness manifests before the age of 25, that of treatment rates for young men, aged 16 to 24, who suggested they had a mental illness last year that needed assistance, only 13% of them got any care. So there are big gaps in the way we provide things, and our money is split between federal and state governments and others, but that gives you a quick indication. Now, I understand the Commonwealth Fund are doing a presentation later on this afternoon. If anybody wants to come and help me badger the Commonwealth Fund, then about how you compare across countries, then you're welcome to do that. I think Australia regularly is shown as having the 2nd or 3rd best health system in the world, and that's largely because they don't count mental health. Now, I did some research myself about mental health in Australia, and there are 95 countries that have a lower rate of suicide than Australia. There are 25 countries that have lower rates of homelessness. There are 19 countries that are better at finding employment, education and training than Australia, and so on. We spend about 7 countries that spend more than us. We have the 3rd and 4th highest rehospitalisation rates for schizophrenia and bipolar. So I think this is really important. So my contention with the Commonwealth Fund, not to be distracted from what we're doing here this morning, is that we need to be thinking about mental health if we're going to take a whole of country comparison kind of approach. Anyway, Australia has got a lot to do. I said we have 5 plans, and here they are. Well, here's the last one of them. And what it did was it sheeted home responsibility to regions to commission and deliver services. And it expected that these primary health networks, these primary health networks, would work with local health districts, local hospital districts, the state-funded tertiary care, the hospitals, and ambulatory-funded or state-funded ambulatory care will work together. And there was a concept of stepped care to counter this lack of integration. But overall, if you've got the federal government funding hospitals, and you've got the federal government funding GPs and primary care, and you've got the state system funding hospitals, who's funding the services in the middle? I won't spend long talking about this. You know more about this than I do, but obviously integrated care has a focus on prevention and primary care, and there's different types of integration, real, virtual, and so on. And we thought that this set for us a very nice platform for us to work together. And there were important principles of equity and holistic care which fitted well and remain well suited to our local ACT government. So who are we? It's a very pretty place where I live. But as you can see, it's a tiny dot in a large landmass. It houses Canberra, and it has about 420,000 people. It's the second fastest growing region in Australia, 9,000 people a year, which is quite a lot from an Australian point of view. And you have to think about how many roads, how many toilets, how many schools, how many ovals, and so on. There are about 80,000 ACT residents with a mental health problem every year, and about 33 Canberrans die from suicide, and we don't spend the smallest amount of money. We're a middle-ranking spender, and we have very high rates of community follow-up. So in my mind, as a layperson, if you like, thinking about integrated care, the basis, again, the platform for us to undertake work around integrated care seemed okay. The community follow-up suggested that the link between the state-funded hospital service and the federally funded primary care service was probably not working too badly. So we have some advantages. We have a small-sized geography. We have relatively small demand. We have got a small workforce. Now, I put that down as an advantage, and maybe this is just being naive, but the reason I put it down as an advantage is because everybody knows each other or is married to one another. We'll come to that later. So we have a relative abundance of services as well. So that's also in our favour in comparison to some parts of Australia. There are services around. There's also been some continuity. We've had lots of changes in the way the federal government and the state government organise themselves and organise their funding. But the Primary Health Network, the PHN, and ACT Health, the local state-funded service, have been working together for some time. They know each other. We've got the lowest rate of seclusion in Australia. We have a well-educated population, and there are no rural areas. Again, in Australia, there's some massive distances, and David can talk about that. In terms of access to services in rural areas. But in Canberra, we are a city-state. Disadvantages. So we do have some shortages, particularly in things like psychiatry. We've also got evidence of more corporate organisational structures managing primary care. So there used to be local, small GP businesses, if you like. Now we're finding bigger GP businesses moving in and creating large corporate businesses with perhaps less attention to your needs, your particular needs. There are lots of organisations. Our, if you like, left-of-centre government in Canberra has always funded the social sector, and so there are lots of organisations that are operating. And unfortunately, that makes connections quite challenging, which is why I've talked about herding cats. The cats all go off in their own way. It's very difficult to make people work together in that regard. So there are lots of gaps, that means, between organisations for people to get lost in. Luis Salvador Carullo, who's a great friend of IFIC, has developed the Integrated Mental Health Atlas and has applied it in the ACT. and has found that we lack acute and subacute residential care, we lack day care. I have to say that's a term that is hard to understand in an Australian context, but I know what he's talking about. We also have a paucity of employment-related services, and we also lack services for what is a very extensive non-English speaking community in our town. So, an integrated regional plan for the ACT. What did we do? We did the sort of things that people do. I picked up the manual and opened it up on page 1, and this is the sort of thing that you do. You form a management group and you go beyond health, because mental health is about the social determinants of health as well as it is about clinical services. It's about psychosocial, it's about quality of life and so on. And it included education and housing and the community sector, consumers and carers and others. From that group we formed an action group, and we developed case studies of typical patient journeys, which sort of represented something like 80% of the core business of mental health in the ACT. We looked for those case studies at where there were blockages now, and we looked at possible points of novel intervention. What could we do in this journey to try and make it easier for the person and for their family? And then we exposed those journeys to broad critique, to the community, to consumers, to carers, and online. And then out of that we developed a list of possible places to start. So I reckon that looked pretty good, pretty robust. What did we find? Well, we found that service integration was a really important theme which underpinned the places to start, because people saw there were silos. Are you funded by the state? Are you funded by the federal? Are you an NGO? Are you a government organisation? And we also found, again, not surprisingly, that what people wanted to see and could recommend was the idea about bringing funds together. Co-commissioning. Shared care, more of an idea around the IT and information management type things to support shared approaches to care. A focus on the workforce. People understood that you can't do anything unless you have a supported and healthy workforce, and that's not the case in many parts of Australia, including Canberra, in relation to mental health. And people also wanted to shift away from using the hospital as the front door of care, and to shift more towards prevention, early intervention in the community. So what has happened? Again, to this point, in my mind, I'm thinking I am helping manage a process that has got some integrity. I use that word carefully. So what happened in the meantime? Well, the public ACT state-funded mental health service split into policy and provider arms. Don't ask me to explain why. The federal government also said, yeah, like the idea of regional autonomy and the primary health networks, but whatever you do, it needs to look like this. So the limits about autonomy, I think, are becoming more clear, more central control. There's also a new Office for Mental Health that's been established in the ACT that had to be accommodated in its role. So I think we're starting to get to the rubber hitting the road here. Having clients in common is not necessarily enough of a reason for key players to come together. Most of their clients and most of the focus of their work are, and of course the dollars which underpin their actions, are all separate. In a big picture, if I can be very crude about this, the federal government, through primary care, if you like, pay for a response to high prevalence disorders, anxiety and depression in particular, whereas the state-funded services in hospitals would be more likely to look for and respond to people in acute need, often with low prevalence disorders, bipolar, schizophrenia and so on. So even where you're able to map a group of shared clients, they aren't all separate, it's still difficult to create space for collective action. We have a large psychosocial sector in the ACT, which is rare. These are people who are providing a whole range of what's called non-clinical support, but they do a whole range of different things to help people live well in the community, and they actually offer something akin to secondary care. But neither primary care nor tertiary care have ever really treated the psychosocial sector like a partner. And now we have a new national disability insurance scheme. We're a very rich country and we're looking to invest in better care for people with disability. But the money for that has come from the psychosocial sector, which means that that sector has been greatly impacted. I guess overall, in looking at this, there wasn't really a clear final model or a destination. There wasn't any funding for change. I was interested to see here Anne Hendry's approach in Scotland, where funding for change around integration, although she was looking at older people in particular, had to be funded. Change is not free. Change costs money. So, I'm winding up. How to create shared value? It seems to me as though even though we all know each other, we can all fit in a telephone booth in Canberra. We've all been doing this for a long time. There still isn't necessarily shared value. So, for example, again, thinking about Anne Hendry in Scotland this morning and other things that you read about the value of integrated care, one of the principles, for example, that would underpin it is hospital avoidance, if at all possible, to try and treat the person before having to go to expensive and often traumatic hospital care. But hospital avoidance isn't part of our fifth plan. It's not mentioned. And then, of course, there's professional and industrial boundaries which negate integration. So there still is a lack of a willingness, if you like, for people to work together. And what matters is the silo. And here an example is that we have a small service that uses coaches or peers to provide low-intensity support based on the UK's IAPT model, and that's proven to be very successful. But there are concerns around that because they're not seen to be professional. So how do we support service integration with the funding integration necessary to support new approaches? Because palpably our funding does not support integration. And how do we establish effective outcomes reporting without perpetuating a culture of blame? And I'm just sort of finding this out as I'm talking to some of the staff in our psych wards look like they have PTSD because they are used to being blamed for failure. And so how do we create the situation where we can collect and report information without encouraging this concept of blame? And if that's just a selection of some of the key jobs, I feel again as though we've been concentrating very much on the funders and on the service providers and the professionals and so on. How do we do all of that and try to keep the patient and their family at the centre? And that's really a critical matter. So I'm looking for any help or suggestions, and I apologise for my fraudulent conduct. As I say, I think that we are here and integrated care is there. It's a very long journey, and what I'm looking for in this context from you would be some help about even some small baby steps to get me started in the right direction. Thank you.
Thanks, Sebastian. We're now going to do a quick trip off to Denmark, and Julie Grew is going to perhaps provide us with some inspiration about how Sebastian and the Australians might address our problem. And then we're going to return to Sydney, which at one level is one of the most beautiful cities in the world, and another level faces very similar sorts of challenges to the challenges that Sebastian has just outlined. So, Julie, welcome.
Okay, thank you for this opportunity to present our work. My name is Julie Grew, and I'm a senior researcher at the Center for Clinical Research and Prevention in Copenhagen, Denmark. Today I will talk about the development of an intersectoral intervention for patients with severe mental disease and selected somatic chronic diseases. And on Wednesday, my colleague and the project manager, Anne-Marie Lyngsø, will talk about the implementation and some preliminary results. The background for the project is, as many of you probably know, that persons with mental disease live 15 to 20 years less than the general population, at least that's the case in the Nordic countries. That this excess mortality largely can be attributed to somatic disease, which to a high extent can be attributed to physical inactivity, unhealthy diet and side effects from drugs, and that underdiagnosis and undertreatment of somatic disease in this patient group is well documented. The aim of the project was to develop an intersectoral intervention aiming to optimize detection, initiate treatment, and ensure treatment compliance of selected chronic somatic diseases among persons with severe mental disease. And we assumed that an intersectoral approach would be appropriate because we identified part of the problem to be that psychiatrists naturally focus on treatment of the mental disease, and general practitioners also tend to pay most attention to the psychiatric diagnosis, and so any somatic diseases may very well be overlooked, but could actually be treated in one setting or the other. We also thought that it would be important to involve the municipality, because the municipal contact person often has the strongest and sometimes the only relation with the person with severe mental disease. We chose a modified version of experience-based co-design to develop our intervention. We established a project group and a steering committee in which general practice, the local mental health center, and the municipality of Copenhagen were represented. We did observations and interviews with general practitioners and with staff at the mental outpatient clinic and the municipality. We visited persons with severe mental disease in their homes along with their contact persons. We met with all stakeholders and we discussed early drafts of the model with decision makers in the field of organization of services concerning psychiatric and somatic treatment. And when the model was developed, we initiated the implementation with a kickoff meeting for all the professionals who were going to be involved in the intervention. The co-design process resulted in identification of these actors you see here and their roles in the project. General practice was appointed as the primary intervention site because all citizens have a GP, whereas not all persons with mental disease attend the mental health center. The GP or practice nurse identifies eligible patients and arranges ongoing consultations with the patient in the project. If the patient has a contact person from the municipality, this person helps the patient to attend the scheduled consultations at the general practitioner and to redeem prescriptions. The mental health center provides supervision for GPs in relation to the patient's psychiatric diagnosis, and the Department of Clinical Pharmacology gives opportunities for sparing in relation to medication of patients to avoid medication error and inappropriate medication interactions. And if possible, the patient's family and/or social relations are involved in arranging the course of treatment to support the patient in complying with the treatment plan. And in the middle is, of course, the patient. And on the next slide, I will tell you about the inclusion criteria we set up. Based on expert advice from GPs and psychiatrists, we chose to include patients between 36 and 65 years of age, and patients with schizophrenia, schizoaffective disorder, and bipolar disorder. We were forced to exclude persons living in social psychiatric residencies because another intervention targeting these patients was being planned at the time. And we were also forced to exclude non-Danish speakers because we couldn't afford assistance from interpreters at the numerous consultations planned in the project. We decided, again based on expert advice, to focus on 5 somatic diseases or conditions, namely cardiac ischemia, heart failure, diabetes type 2, hypertension, and high cholesterol. And to beat any questions on this, we did not include COPD because the main treatment is smoking cessation, which was regarded as particularly difficult in this patient group, and because the medication is very expensive.
which was expected to cause a risk that many of these patients in this vulnerable group wouldn't afford it. We ended up with a model that includes a screening phase and a treatment phase. And the screening phase starts with the GPs identifying eligible patients in their electronic record system. Patients who meet the inclusion criteria are then contacted by the GP or the practice nurse with the information and an invitation to participate. If the patient wishes to participate, an appointment is made. And if the patient has a contact person from the municipality and would like to be accompanied by this person at the consultations, this person is also contacted. The patient then receives written material, a text message, and an audio file with information about the project. And the day before the scheduled consultation, the patient receives a reminder from practice. Patients who attend the scheduled consultation and give consent are then screened for somatic diseases. If the patient does not attend the consultation, the nurse seeks to schedule a new appointment. And if the patient still does not attend the consultation after the third scheduled appointment, he or she is excluded from the project. Patients diagnosed with one or more somatic diseases are included in the treatment phase and receive an individualized course of treatment in accordance with current clinical guidelines in general practice, in collaboration with the patient and his or her family, and with support from the contact person, the mental health center, and clinical pharmacologists. And each patient who is diagnosed with one or more somatic diseases is then followed for 1 year in general practice, and 3 to 4 consultations plus a final annual checkup are expected. So the developed model differs from current practice by introducing a new way of identifying and actively recruiting patients with severe mental disease for screening for somatic disease in general practice, and by strengthening the intersectoral collaboration. The main element of the intervention is an extra effort to make the patient attend general practice and to maintain the patient in the course of treatment. And this extra effort includes phone calls and a personal invitation to a screening consultation, reminders of appointments, extra time for consultations, support of the patient from his or her contact person, and support of GPs from psychiatrists and clinical pharmacologists. And also it is recommended that the patient, wherever possible, meets the same staff at every consultation in general practice. Our co-design process also resulted in a set of tools for the GPs and detailed descriptions of procedures for all involved professionals. Here you see the project folder that we created. It contains everything that the participating GPs need in the project. That is information material for the patients, phone numbers on all involved partners, envelopes, etc. And these data registration sheets you see here. On the first one over here, all patients extracted from the record system with one of the diagnoses are listed, along with age, sex, the reason for exclusion, if that's the case, and consent to participate, and other data. And on the other sheet over here, this sheet is filled out for each participating patient, and it contains information about any somatic diseases that are found, and the dates of the consultations, and lab results, and some other data that we use in the evaluation of the intervention. So we can conclude that a modified version of experience-based co-design is a suitable methodology for developing new ways of organizing services within mental health care. We can also conclude that it is essential to involve stakeholders from the project definition phase and throughout the development process in order to design a feasible intervention. And by a feasible intervention, I mean a model that requires incremental changes to the current organization of services, because this optimizes the success of the implementation. And lastly, I want to mention one of the limitations of the study setup presented, namely that the payment that GPs receive for consultations in this project is slightly higher than usual to compensate for longer consultations and data collection. And because of the way GPs are paid in Denmark on a combined capitation and fee for service basis, implementation of the model after the project period would require either changing the collective agreement for general practice or assigning responsibility to nurses who are cheaper and are paid differently, which would actually allow them to do this work as part of their usual tasks. Thank you, that was all. And I hope to see you on Wednesday at 8 o'clock where the implementation and some preliminary results will be presented in room 8 and 9.
Thank you, Julie. I think we've got time for a question, if there's anyone who'd like to ask a question. I can't see anybody with a hand up, but then I can't see very much. Okay, we'll take some questions at the end. Thank you very much, Julie. And now we're moving to our third paper, which is back to Sydney, and Dr. Kathleen Smith. This is the first of 3 papers on things that are happening in Sydney. So welcome.
No, there, you put me as number 4. Yeah. Yes, that's me. Yep. Thanks. Okay. Okay. Yep. Righty. Buenos dias. My name is Kathy Smith and I'm a psychiatrist from Sydney, New South Wales, Australia. I work at Concord Hospital in the Sydney Local Health District. And I'm here to present today on behalf of the team that I work with at the Collaborative Centre for Cardiometabolic Health and Psychosis. Oops, I've gone a little bit too far. Our unique service-structured model of care has been designed to overcome some of the barriers that persons with severe and enduring mental illness face in negotiating traditional healthcare structures in the Australian setting. The purpose of the innovation is to reduce the preventable premature mortality relating to cardiometabolic disorders in this group. For those members of the audience who do not have a background in mental health, I'm going to take a moment to put into context the need for this innovation. 2 Australian reports, the Duty to Care in 2001 and the Australian National Report on Mental Health and Suicide Prevention in 2017, both showed that people with severe mental illness are likely to die earlier than those without mental illness, and that those deaths are often due to preventable physical health disorders. For example, people with severe mental illness are 6 times more likely to die from cardiovascular disease. That there was no improvement in the 16 years between these 2 reports illustrates the failure of traditional Australian health service models to address this issue. It is important to note, however, that this is not just an Australian issue. The global tragedy of excess mortality among people with serious mental illness transcends geography, different systems of healthcare, and different approaches to healthcare financing. According to the European Union, the prevalence estimate of lifetime mental health disorders in Spain is 19.9%. So Spain then, like Australia, faces the prospect of significant physical health morbidity and mortality among those with mental illness. And sadly, most of this preventable premature mortality is preventable, and the gap is widening. So in the 2005 Australian census, that was proven. So this is the current trajectory of life expectancy. And this is the trajectory of life expectancy with those with severe mental illness. Hopefully in the next census we'll find some improvement. The Australian Health Commission has called this an injustice that runs contrary to the United Nations principles for the protection of persons with mental illness. and subsequently asked the question, what model of care would provide comprehensive, effective, integrated physical health care to people with severe and enduring mental illness? So arising out of this need, sorry, I'm a little bit quick there. Arising out of this need to do something to change the health of consumers with severe mental illness, the Collaborative Centre for Cardiometabolic Health in Psychosis has evolved. It has been a work in progress for more than a decade, but in 2014 it was established in its current form as an outpatient service by 3 doctors a little bit ahead of the curve. Professor Tim Lambert, Professor of Psychiatry at the University of Sydney, Concord School, Associate Professor Roger Chen, an endocrinologist, then also of Sydney University and Concord Hospital, and Dr Jeff Snars, a psychiatrist at Concord Hospital in the Sydney Local Health District. And we refer to them affectionately as the 3, the picture hasn't come up, sorry, the 3 founding amigos of CC-CHIP. So, what is CC-CHIP? We're not a food, even though we sound like one. The Collaborative Centre for Cardiometabolic Health in Psychosis is a multidisciplinary, integrated, consultative service that aims to assist healthcare providers to effectively screen, detect, acutely manage and monitor a broad range of cardiometabolic risk factors among adult consumers with severe mental illness. CC-CHIP provides an opportunity for consumers with mental illness to see multiple specialists and clinicians in one afternoon that would usually take months, if not years, in the Australian sector to see. The clinic places consumers at the core of its business and integrates with a wide range of services and stakeholders to deliver the best possible service through evidence-based practice. By combining this innovation in service delivery with patient-friendly visual feedback and digital risk calculation, CC-CHIP aims to reduce this premature preventable deaths. So in the Australian context, the primary medical healthcare provider is the general practitioner or GP. To effectively manage cardiometabolic risk, though, in those with severe mental illness, in addition to the GP, the consumer might need to see a psychiatrist, cardiologist, endocrinologist, dietitian, exercise physiologist, nurse and/or dentist. So the traditional and current Australian outpatient healthcare model would involve the consumer and/or the GP identifying the cardiometabolic risk. The GP would then need to refer the consumer to up to the 7 clinicians. The consumer would need to negotiate booking those 7 appointments within either the private or public health sector, travel to each appointment, pay any out-of-pocket expenses relating to these appointments, not all of which are covered by our universal healthcare system. It is likely to take some time to see all practitioners, perhaps even years, as waiting times in the public sector for health issues that are not considered urgent can be in the order of months. You can see there as our little man makes his way from specialist to specialist, his number of referrals in his left hand is decreasing, but so is the amount of money in his right hand. So if the consumer has persisted, they then need to implement any of the recommendations made. As you can see, to complete this round of consultations would require motivation, organisation, the ability to persist, financial resources, and the cognitive ability to recall, process and use the mostly verbal information given to you by the respective practitioners. Some, if not all of these requirements would be difficult for those with serious mental illness. Further, the lack of integration between healthcare providers results in consumers feeling confused by conflicting advice, or it may require the consumer to take carriage of the communication between healthcare providers. This is a challenge for any consumer, but especially so for those with serious mental illness who often lack the confidence or agency to ask questions. So what then is different about CC-CHIP? The CC-CHIP model of care inverts the traditional service model by gathering all 7 practitioners together in one clinic and bringing the consumer to that clinic. This creates a one-stop shop which places the consumer at the centre of the clinic experience. Prior to the clinic, information is gathered, including a referral from primary care provider, medical and other history, pathology results and a medication summary. This ensures that the consumer does not need multiple visits for the assessment and that the team can also spend more of the clinic time on intervention. Lost my slide. Okay, so then the pathology collected to assist in the assessment of cardiometabolic risks includes, among other things, fasting glucose and lipids, HbA1c, apolipoprotein B, and high-sensitivity C-reactive protein. So then as the consumer moves through the clinic, they start to develop an understanding of the state of their cardiometabolic health and to accumulate a written plan regarding actions to change their health. The consumer does not pay for the service, as we use a combination of existing funding models within the Australian healthcare system, combined with financial support from the Sydney Local Health District under a program entitled Living Well, Living Longer. All team members are experienced in working with consumers with mental illness and as such are able to tailor their intervention to the consumer's needs, capacity and supports. This means that any goals and plans that are made are sensible, achievable, affordable, of meaning to the consumer and build on that individual's strengths. At the completion of the clinic, the practitioners meet for a multidisciplinary case conference. Each consumer's history, pathology and calculated risks are reviewed. The team is then able to consolidate the evidence-based but highly personalised set of recommendations for each consumer. The consumer's cardiometabolic risk and the recommendations to address this risk are conveyed to the consumer's primary care provider, the GP, and to the mental health team in a comprehensive letter. The Sydney Local Health District Mental Health Service has developed with local general practitioners the Mental Health Shared Care Agreement. The purpose of this is to derive a shared understanding between the mental health service and the GP about who will take responsibility for which aspects of a consumer's physical health care. Mental health care coordinators support the consumer's attendance at the CC CHIP clinic with a visit to the GP after the clinic in order to follow up the recommendations captured in the letter. This completes the integration of care. And you can see where the arrows are that CC CHIP is an integral part of the Mental Health Shared Care Agreement. So I think many of you would be familiar with working with multidisciplinary teams, but the functioning of our team is enhanced through the use of integrated and complex information technology innovations that have multiple benefits to the consumer. So I've expanded now our CC CHIP team to include our information systems. So the CC CHIP database is a multi-purpose instrument that captures, stores, processes, uses and expresses in real time all the information that each clinician needs to assess and manage the cardiometabolic risk of mental health consumers. During the clinic, each clinician contributes to the live database of information. This improves the accuracy of each individual consumer's cardiometabolic risk assessment. And this is important because the more specific that any risk assessment is, the more useful it can be for guiding treatment decisions. The AHA and ASCVD risk algorithms automatically calculate and are available to each clinician. As knowledge accumulates in the database, each subsequent clinician can use this to educate the consumer and plan more personalised interventions. Each clinician can see the other's information and intervention at the time of their own consultation. And this minimises confusing or conflicting feedback. So in general, people with serious mental illness, although they might have significant cognitive problems, have a relative sparing of their visual processing efficiency. So each aspect that relates to the cardiometabolic risk, such as BMI and waist circumference, lipids, glucose and blood pressure, are subject to a colour coding: green for healthy, amber for to be concerned, and red which indicates needs immediate attention. This serves a dual purpose. Non-medical clinicians can appreciate the severity associated with the risk parameter, as can the consumers, with green, amber and red having a universal meaning. The greatest benefit really of this CC chip integrated IT is definitely the ability to educate, engage and motivate the consumer about their health. Consumers with severe mental illness have cognitive problems that impact directly on their capacity to process information. People who are completely disengaged can stop, learn, look and concentrate hard as they start to truly appreciate the state of their health. This slippered dashboard, for example, will pop up live. The black line, which represents the consumer's actual test result, sort of slides into position, and people can start to see quite visually for themselves where their health is at. And it's not uncommon to get the comment when they see their black line in the red in quite a few squares, that's not good, is it? The power of this is really that even consumers who are quite sort of impaired and have quite a long-standing kind of cognitive deficit or blunted affect will actually get engaged by seeing this on the screen. And those that have been engaged can shift further into action. I'm just going to very quickly, before I finish, show you our heart age simulator. So you can see on the right, in the amber is the patient's actual age, and you can see on the left the Framingham calculated heart age. And you can see the quit smoking, reduced lipids and reduced blood pressure. So in real time in the clinic, you would sort of show them that and explain to them that their heart's under considerable sort of strain and is more like the heart of a much older person. And then you would say, hit the quit smoking button. And they would see the dramatic drop in the heart age if they were to quit smoking. And then if you were to hit the reduce lipids button, you see a further drop again. So that's a very powerful way of giving people feedback. I think there's a very emotive connection to the heart, which continues to be understood even if there are severe impairments. So CC Chip is an innovation in service delivery that provides comprehensive and integrated physical health care to people with severe and enduring mental illness, which uses patient-friendly visual feedback, digital risk calculation, and is integrated with existing information technology infrastructure and other services. There's a website, and Professor Lambert, who's the director of the service, would be very happy for you to contact him by email. And thank you for the opportunity to present our small example of integration in this vast ocean of integration need. Thank you.
Kathleen, sorry to hurry you. Is Lisa with us? Please. I don't think that is Lisa. I'm quick on the uptake. Okay, I think we will move on to Lee, again from Sydney Local Health District. It's interesting to observe that within the structural challenges that Sebastian outlined, it's possible to do good and relevant work that makes sense both in a specialist setting in Sydney and also in a primary healthcare setting in Denmark. Lee, please.
Good morning, ladies and gentlemen. My name is Lee Zhang. I'm the manager of Partners in Recovery New Horizons in Sydney from Australia. You may ask, why being a Chinese woman presenting an Australian project in Spain? You can call that globalization, or you can also say that's integration. And being the third Australian speaker in this section, I will want to demystify that not all Australians look like the actors and actresses in Bondi Rescue. In fact, the photo underneath is actually an actual street view of the suburb I worked in. In that suburb, we have 20% of population speaks Chinese as their first language. When we think of Sydney, of course you think about the beautiful harbour views. But like all other major cities in the world, there are a lot of people experiencing poverty and homelessness. And that's what makes the better pathway to housing projects for mental health issues projects meaningful. The Better Pathway to Housing projects takes place in the Sydney, inner western Sydney. The area has a population approaching 800,000. It includes part of the inner city. It includes part of the inner city. When it goes to the further west, it becomes quite suburban. Of course, it's very multicultural, as I'm here to testify that. It's a stone's throw from the Harbour Bridge, and one of the closest beach is Bondi, which is about 10 kilometers away. The principle of these projects is that appropriate and stable housing is one of the prerequisites in helping individuals with mental health problems achieve and sustain their recovery. The project has 4 components. The first one is senior leadership. The project reports to the Healthy Strong Community Steering Committee as part of social reform led by the Australian government. The membership of Better Pathway to Housing consists of senior managers from health, family and community services, partners in recovery, community housing providers, and a consumer representative. A local government council has been included in the membership later on. Not only can we make decisions, but we also have the influence for systems change. When we first started in 2015, we experienced blockages between multiple agencies. But the committee determined to make a difference while we're facing very complicated issues. And all these issues are intertwined and can't be solved with one single solution. Just to help you understand what kind of issues we were facing, I have a sample here. In our local area, 25% of people discharged from mental health inpatient units go to unstable housing. Over 6,000 people lived in boarding houses. In fact, in our local areas, we have 43% of the boarding houses of the state. The wait list for public housing is long. When I say long, I mean people have to wait over 10 years in order to get a place in public housing. Even if they're lucky enough to get onto the priority list, they still have to wait for over a year. As you could imagine, for people with severe long-term mental illness, 1 year is a very long time. Anything could happen. Fourth, the funding for supported housing, they were from different sources and they're quite disconnected. These slides just demonstrate a level of support and stability in housing model. So we have unstable housing at the bottom, and then boarding houses, community social housing, supported accommodation, and have hospital at the top, having the highest support. As you will see, there is a gap here between supported accommodation and hospital, and that's the major area the project had looked into. And these slides demonstrate we have took actions in multiple areas, and we have filled the gap. Where's the pointer? Here. The project started in 2017, so 4 years on. The project's still going very strong, and we have achieved amazing results in 4 areas. The first one is strict rough sleeping. The project initiated the strict counts. The count occurs at midnight, and all rough sleepers are counted by a group of volunteers from service partners. One of the actions was one of the community managed organization has found a outreach support worker to work with this cohort. Second, boarding houses. As I said, 43% of the boarding houses in the state is within our local area. So the first thing we did was to map what's out there. Although boarding houses provide an affordable alternative for homelessness people, most residents in the boarding houses are disconnected from their families, others, and services. In order to help the residents in boarding houses, a multi-agency partnership has been set up. We set up a new service called Better Boarding Houses Community Living Support Group. This is a wrap-around support model to work with people in boarding houses. 3, public and social housing. We know that health and housing are not always working in good terms, and they can be quite disconnected. Therefore, with the projects, we have the Department of Health and Department of Housing actually has signed a service agreement to employ a mental health social worker to be the clinician between housing and mental health. These clinicians also help with fast-tracking the housing applications for people with mental illness, with severe mental illness. 4, supported housing. When we did the mapping, we realized there were 54 supported housing beds in our region, and most of them were orientated to low support needs, like 4 hours per day. A subsequent plan was to increase the beds for medium, high, or even 24 hours support. This has been successful. So far, we have 69 supported accommodation beds in the region, and 33 of them are medium, high, and 24-hour supports. And we also created a system to make the supported housing more integrated. So I'm going to talk more about the 2 24-hour support models. The first one is Urella House. The Urella community-based alternative model is the first model of its kind in New South Wales. The model is a collaborative partnership between Sydney local health districts and New Horizons, a community-managed organisation. The Urella facilitates relapse prevention and recovery promotion. It provides more intensive community support or divert people from hospitalisation, which is a step down, as well as providing residential support services following discharge from hospital, which is a step up. So the Urella House provides 24 hours overnight support by New Horizons and the residential support workers. The clinical and allied health staff member employed by Sydney local health districts, they work in shifts in the house. There are 10 beds accommodating for both men and female and women in the house. The length of stay is maximum 28 days. The other 24-hour support model is Camperdown units. The Camperdown units commenced in July 2017 to provide a new model of residential supported housing to people with higher mental health needs. It's a partnership between a community-managed organisation, Sydney local health districts, and a community housing provider. The program cooperates 11 consumers in their own units. There are 24 hours overnight support on site. The clinician from the Sydney local health district provides drop-in support to the residents in there. The length of stay in Camperdown units is as required and expected to be at least 2 years. We also developed an online referral pathways for all supported housing. Due to the funding and historical reasons, there were several paper-based referral pathways to supported housing, and they all managed by different organizations. Most of the information were installed in a staff member's head instead of in the system. So when the clinician wants to make a referral or find the best fit of support accommodation, the clinician have to make several referrals just to try their luck. Not only this was time-consuming, it also allowed people to talk about consumers' information in different forums. Therefore, this online referral pathway has the information of different houses and the referral pathways and the key contact person. A key clinician also appointed to be the person, central point for all the referrals for supported accommodation. What remains to be done? In the plan of 2018-17, the better path, 2018-19, the better pathway to housing projects will continue to refine all the areas we have started. We're determined to create a more integrated model for housing pathways for people with severe and inducing mental illness. If you like to consider this model for your own area, I would suggest you look at these 4 key areas: supported housing, public social housing, boarding houses, and rough sleeping. Last but not least, I would like to thank the integrated teams behind me to make these projects successful and also make this presentation possible. Thank you.
Thank you, Leah. We'll have some time for some questions at the end. We've now got an oral poster session, which is a 5-minute session, and that should leave us some time to discuss a number of the issues that have arisen. And our presentation is by Sophie Thunes from Belgium. So please come and join us.
Hello everybody, my name is Carol Walker and this is Sophie Thunes. We come from Ussel-Louvain, Belgium. Today we're going to present our poster, which is about a social conception of policy change in the context of mental health care. So this poster draws on 3 research projects that were carried out in Belgium on the mental health care organization. The policy change was initiated in 2010 with the 107 reform. The aim of this reform is to shift from a hospital-based towards a community-based model of mental health care through the development of local and integrated care networks, which aim to get professionals from different services and sectors to work together and realize 5 care functions. So, what does policy change mean? Policy change in this context refers to a revised conception and organization of mental health care in which is processual and in which communication unfolds between different social systems continuously. In policy change, roles and relationships are constantly evolving between key stakeholders. So, a social conception of policy change involves communication between different social systems and it contrasts with a traditional approach to policy analysis in which different phases are separated between conception, implementation, and evaluation, and also between different levels of action, which are international, national, and local.
So a social conception of policy change is based on 5 key elements, which are documents, projects, coordination, meetings, and practices. These elements are viewed as strategic aspects of the social life of mental health policies. In the framework of this presentation, I will give more details on 3 aspects, which are documents, coordination, and meetings. Regarding documents, the example of this presentation is a policy guide, the policy guide which defined the Reform 107, which is currently implemented in Belgium. The purpose of a document as a policy guide is to stabilize the initial meaning, the initial objective of policy change in the field of mental health. This stabilization of meaning occurs, among others, through references to other documents. An important aspect of document is that they are material support, which are able to circulate and to convey meanings through time and space. However, documents which are issued by the political system need then to be interpreted in different systems. Meetings. Meetings are precisely spaces required for the interpretation of documents. There are also social spaces where different social systems communicate with each other. In the framework of a meeting, each system communication is an occasion for another system to observe a difference relating to how mental health care is conceived and how mental health care should be organized. So different conception of mental health care and how mental health care should be organized are enacted or communicated through meetings. However, meetings are only transient interaction systems, meaning that they last no longer than the interaction, than the meeting itself. Accordingly, the important question, if you want to understand, according to this conception, if you want to understand which direction policy change is following, the important question is to understand how a particular conception of mental health care is finally selected and how different pieces of knowledge and information are articulated together and stabilized. This is part of the work of coordinators. Network coordinators are a new type or relatively new type of professionals responsible for steering the development of projects in the field of mental health and responsible for organizing and sharing meetings as well as reporting on meeting communication. The very specificity of this new kind of professional is to draw on informal sources of power. The most important source of power is their management of process. So what does it mean? It simply means that by dealing with process, for instance, through organizing and sharing meeting communication. Then on reporting on meeting communication, coordinators are in a position to select which information or which type of conception of mental health services should be retained, and then to inscribe it in documents. So over a process of 5 to 10 years, coordinators are just selecting piece of information, articulating them together, and giving sense to policy change. In conclusion, based on this social approach to policy change, can we hope to exert any control over policy implementation? It's very difficult to exert control on meeting communication, on the selection process, because it is very contingent on interaction and communication, but with these key elements of project management, coordination, and meeting management, we can find a way to improve the way we are dealing and trying to orient, to give a particular orientation to policy change in the field of mental health. Thank you for your attention.
Thank you very much. Please stay on the stage, and we'll take some questions on all of the presentations. If you're speaking in Spanish, I will put on the headphones and try and relay the question in English. But please, questions to any of the speakers, or general comments that people would like to make. Please, over there.
Hello, I'm Dr. Nazla Siddiqui from University of Tasmania. Great to see all these successful projects from Denmark, from ANU, Belgium. What I would like to know from the project with the doctor at that multidisciplinary team, did you mean when a patient comes in, you are having all of those required clinicians in the same room? Was that something done face to face?
Clinicians individually in the one afternoon. So the patient arrives, we do 2 clinics a week at the moment. They arrive at about 1 o'clock and they'll see each person in succession. And then on occasions, for example, the endocrinologist and the psychiatrist usually work together. So they'll see the people together at the same time. So the patient will go to each of the clinicians or practitioners, and then at the end of the day when the patients leave, we all get together and kind of consolidate the advice and the plan.
Can I ask a supplementary question to that, and that is, how do you connect to the GP?
So the GP is the person who refers the patient in, and they receive a very comprehensive and detailed letter about the patient's visit. So it details the cardiometabolic risk as we have assessed it. It will detail what we believe should be done in terms of managing that risk. And that involves also linking the patient to a variety of projects in the Sydney Local Health District, such as community mental health dietitians, exercise physiologists, and a healthy lifestyle group. So the GP gets that very comprehensive letter back. Some things enacted, some things for the GP to enact.
Possible to have an online collaboration where you have, rather than doing the consultation at the end of the day, when the patient is coming in or even from home, you hook in with all the clinicians and do it on an online basis. Because that's something, it's just like how we do online education for our students. So is that something at all possible?
Yeah, I mean, I guess it would be adaptable to some degree, but one of the powerful things about having the patient journey through from clinician to clinician is that it tends to build a bit of momentum in their understanding of their cardiometabolic risk. And that can be very powerful. So sometimes people can be quite overwhelmed, in fact, by the end of the clinic. We try not to leave them in that state, but we try to leave them with the feeling that they've got a clear understanding of their risk and what they can do about it. That's the other part of the equation. And to some degree, I think you could use sort of video conferencing technology to do some of that. But I think it does really, the fact that you're there in person with them, looking at the computer screens, looking at those kind of visual images together, really helps in terms of them coming to an acceptance of the need to do something to change their health.
Okay. Are there other questions? Please. The lady on the right-hand side. Oh, okay. Maybe over there first.
Yeah. I have one question about the first presentation. You said that family practitioners are working more now in a group practice, but in Estonia we are moving now to the group practice. But how you motivate them to do that?
Sorry, was that a question for Sebastian? I think so.
That's a great question. I think that working with general practice in Australia has proven to be one of the most difficult parts of any change process. And so I guess when I think about that, I think about a particular project that's led by champions that is able to create some integration. But you're asking me now, I think, much more about a whole of system approach to integrating primary care. And I have to say, I think that's become very difficult. Let me give you an example. There was information that was provided to service users about which doctors were interested and good at mental health. Many people would say that that is gold. That information is gold because it saves so much time for consumers and carers to find the care they need. But that information was not able to be kept going. It in fact lasted for only a matter of weeks before the rest of general practice said, hold on a second, not happy about having some doctors identified as being mental health friendly and some not. So I'm just suggesting that it is a very mixed picture. Again, David's well placed to talk about this rather than me, but if you are in a rural area or in a regional area, you will find some general practitioners will have no alternative but to be integrated into their community, to be working potentially with their local nurse, to be working potentially with their local school teacher, with others, because there's no choice. But in some of the urban areas, these larger corporate structures are mostly geared around making money, much less around providing care. And of course, particularly for people with more complex conditions, they may need more than 15 minutes of the general practitioner's time. And that doesn't pay. So one of the big things in Australia that we're trying to grapple with now is how we pay to provide an appropriate incentive for GPs to spend time with people with more complex conditions. I hope that partially answers your question.
There was a question from the lady here.
Thanks. I'm Caroline Potter from the University of Oxford. I just wanted to thank all the speakers because I thought this was a really fantastic range of presentations, just looking at all of the different dimensions that we have to take account of. So having, I think, the housing as an element was really good for getting us thinking about integration in the widest sense. My question's actually for Kathleen. I was glad that you spent some time talking about the integrated information system, because from talking to our clinical partners within the English health services, that seems to be one of the key barriers for any kind of meaningful integration. And it seems like in the local context where I work, a lot of the information systems have kind of grown up organically. So, you know, let alone can we link up sort of all primary care across the country. They're kind of better because at least they have a fewer number of systems, but a lot of the hospital-based systems sort of have their own IT that's all been sort of done in-house. So I wondered if the system that you talked about had been done locally, and if so, what the implications are. You know, if other people wanted to follow your model, would it be sort of be able to be transported into other IT systems?
Well, in setting up the information technology that's used in the clinic, we went right outside the LHD, the local health district. In fact, we were told by the local health district that it wasn't possible to do what we wanted to do. And there was not just resistance, but undermining of the idea that we could make a system where we could integrate with the GP electronically, integrate with pathology providers electronically, get all of that information to come past the LHD sort of security and into our service. So it's been done now. In fact, you know, very shortly this year, we'll have an electronic referral system where the GP is sitting in their office. They make the referral electronically. That will search and find the pathology that the patient has done. It'll send the referral and the pathology directly to us. And when we are completed with our letters, it will go electronically back to the GP. But all of that has been done by a small dedicated IT team lodged within our team. And we have the advantage that we're a part academic team, part local health district team. And on the academic side, we had the freedom to pursue things that the LHD IT system simply would not let us pursue, and in fact told us were impossible. But I'm sure if you wanted some information, Tim would be very happy to speak to you about A, the journey to get there, and B, what we've been able to achieve and where we're hoping to go. But it was all done outside it wasn't done within the public health system initially. They're a reluctant late participant.
But look, this is progress despite the system, not because of the system.
Yes, these are rogue clinicians who are doing something for the patient against the interests and the structure of the system. I was going to ask one question for Lee, sure. And that was whether you're seeing, because you know, we have this idea for people with severe mental health problems that housing is the first priority, and that if people have stable, secure, satisfactory, happy housing, that we have some opportunity of helping them towards recovery. I'm wondering if you're beginning to see evidence of people within the system which you described on a pathway to a better quality of life.
I certainly don't have the qualitative data, but we have seen in the boarding houses wraparound service, we have seen a lot of people actually they went past, jumped the queue and went straight getting a permanent housing, which we couldn't think of before these boarding houses wraparound service, because as I said, the waiting list for housing is 10 years long.
So I wonder to what extent one of the causes of premature death amongst people with severe mental health conditions is actually the lack of adequate and satisfactory housing, which perhaps we haven't thought about in those ways. Look, I'd like to say thank you so much to our speakers. They've been through a circus ring with very limited amounts of time. They've tried, particularly with our poster presentation, to address really complex and difficult conceptual issues without time. So please do come and talk to them afterwards. I guess what I take home is that within environments and systems and structures that are not conducive and helpful towards the care and recovery of people with mental health conditions, we have people who are trying to do real things. And they're for people who have serious conditions. These are life-limiting, life-threatening, life-shortening conditions. and that often in our political systems, mental health is seen as something over there, something that's different, and something that is not a priority in the same way that accident and emergency or cardiac events or other things are. So look, thank you very much to our speakers. Please say thank you to our speakers and enjoy your lunch or your meetings. Thanks, guys. Thank you. Sorry to ring the bell. I didn't know if the other person.
La de antes era la de griego.
Exactly. Good to meet you. Yeah, and it's a subscription journal, so we have no fee. So that's fine. All right. Okay. Thanks very much, and good luck with it. Yeah. Cheers.
No, salimos ya, ¿no?
Yo voy a quedarme a escuchar.
Venga, hasta luego.
Pues buenas tardes a todos y bienvenidos.
Good afternoon, everyone, and welcome. We are here. My name is Neves Edinburgh. I'm a researcher. I work for the IFIC, and I will be chairing this session. It is lunchtime, so let's keep our fingers crossed and hope that people will just grab some food and come and join us shortly. More people will. We're going to be hearing from, we're not quite sure yet, 2 or 3 different speakers about integrated care in the Basque Country.
Speaking session, so just to make sure that you're covered with your headphones. ¿No? ¿Todo el mundo habla español? Perfecto. Pues cada presentación va a ser de 15 minutos. No voy a ser demasiado estricta porque como no tenemos al...
We're going to continue now then with the presentations. They will be more or less 15 minutes long each. There's no need for interpretation, so you can talk as fast as you can.
No sé si lo han estado haciendo.
I do want to remind you and encourage you to post your comments on Twitter. If you have your app, on your mobile phone, this is the way to do it. We can see up on the screen.
Se meten
Is Slido, the program, and then the password will be ICIC 19. We're going to be hearing first from Rosa González Linares from the Basque Public Healthcare. Welcome, Rosa. Thank you, Neves. On behalf of the Chronicity and Integrated Care Service at the Basque Public Health Service, I would like to thank the organizers for giving us this chance to be here today to tell you about our experience in improving integration, which is something that we all want to achieve, and we want to improve at the end of the day the continuity of care and that care pathway for patients. Apologies, but the light is shining in my eyes. I don't know where you come from, those of you who are listening to me. If you come from anywhere but the Basque Country, I would like to tell you a little bit about our region. Here we see it on the map. Some 2,300,000 inhabitants in the Basque Country. The area, the surface area, is made up by 3 different provinces, just over 7,000 square kilometers in total for our region. And we are an autonomous community, which means that in the Spanish political system, we had a number of powers devolved, one of them healthcare, and we raise our own taxes to do so. So we have 2 different structures within our system, one that designs the system and decides on the funding of a system, and then OSAKIDETZA, which is in charge of service delivery. OSAKIDETZA, the Basque public healthcare system, was set up in 1983. We will turn 35 this year. And so since 1983, OSAKIDETZA has been in charge of all the resources, whether it's material or human resources, covering the whole of our region. And then in 1988, well, that was our real landmark, because that was the time when we were given all those powers fully from the government in Madrid. We are happy with our system, with our planning, and our objective is improving healthcare and quality of life through public high-quality services. In 1983, doing so was quite a challenge. And then back in 1990, there was another landmark. We had to comply, well, we decided we wanted to comply with quality systems, originally EFQM, now the Advanced Quality Model. And that continued up until 2008, which is when we decided to tackle the population aging challenge and the chronic pathologies channel. We all know how aging population is a huge challenge. It's not a pyramid anymore. Look how thick that polygon looks on the sides, halfway through, and then the peak just for women. And let me tell you or remind you that life expectancy is very high in the Basque Country. We are one of the longest living areas in the world. We know that by 2040 there will be twice as many chronic patients over 65 years of age, which was around about 20% in 2011. I also want to tell you that we are really changing, transforming, I say, our biomedical model. Not so long ago, healthcare really focused on acute patients and structures, but in 2010 we decided to change our care model. You will see how. Our initial idea was that we wanted to start going towards this integrated care model with people and patients as our focus, and also making the most of the synergies with the community, with the patient's environment, with society. So focusing on health. In 2013 and 2014, we designed our integrated care plan for the Basque region. I would like to recommend you to get a copy of this plan. Just go to our stand outside OSAKIDETZA stand, and we will let you have a pen drive with this, so that there's less fragmentation, more efficiency, and better integration of care in our services. That's what we want to achieve through integration. So how far have we come in this journey towards change and transformation? I'm going to give you very global, very general results, but let me just remind you that the program includes other presentations, much more detailed programs and specificities. My facts and figures will be rather general, as I said. There has been a gradual joining of different units. We had, which is what we call OSIS, and then for mental health, there is a specific network that's been set up as well over the years. Right now, the structure for OSAKIDETZA is 13 integrated organizations or OSIS, 3 networks for mental health, the Basque Center for blood transfusions and human tissue, our oncological foundation, our general offices, headquarters. Well, that's the general structure. We have carried out 4 different stages to better stratify our population so that we can be more proactive and better focused when we target our interventions. Look at that. 60 9,000 people with multi-pathology, with a number of different diseases. And we are addressing them directly, very intensively, for 16,000 of those. We fortunately have good integration for technologies. We have one single history as well for all different healthcare professionals. And that's fully implemented, has been fully implemented 100%. We also have different ways and channels for professionals to ask questions to specialists, and can do so not face-to-face as well. 100% of our hospital services have technology so that doctors and nurses can access patients' history and all information at the foot of the bed remotely. I forgot to mention earlier that the details I'm giving you are the result of our latest report for 2018. And if any of you want more detail, please let me know and we will send you more detailed information. Electronic prescriptions were very innovative, and here we can see the progression over time. The evolution shows that some 27% increase is the trend for prescriptions that are given electronically. You can see here the number of patients that access electronic prescriptions. It's being accepted very, very well. Some 850,000 prescriptions in the year 2018. Here we can see the healthcare folder, which allows for better interaction between patients and healthcare providers. We can see the 3 different channels for content to be included in these folders. You can see also using messaging technologies through training and education.
Ves que ha habido a lo largo de los años un incremento tanto en la consulta de citas pendientes.
We can see that we have been doing much better as well for accessibility, for vaccinations.
OSARIAN, o dentro de lo que llamamos
OSARIAN, it's a health advice that is run by the emergency services, by a group of nurses, 24 hours support all year round. And here, that there is an increase in terms of the number of calls. And the increase is not the important bit, but it's to show how many of these calls are being resolved by this group of nurses. With regards to a social health approach, we have a shared medical record.
He pulsado muy fuerte, ¿verdad? No. Ponme aquí. Aquí, sí. Dentro de los socios.
So a number of priorities have been identified, 2017 to 2020. with regards to the deployment of the RAI-CA as an assessment tool. Out of 594 identified cases, more than 594 cases have been dealt with out of 1,123 cases. And right now, this is something that has been done between the local authorities and health services. We think that the health routes is a tool that allows us to integrate and that brings together different professionals that are involved in, or that have an direct impact on patients with specific diseases and conditions. And a guide is being drafted and will be published this year. And at this guide, we have defined the routes, what are the main key features that these sort of routes should include. And then there's a diagnosis being conducted in terms of what's the status of the existing guides in OSAKIDETZA with regards to the criteria that we consider that the health guide should include. Something else that we have carried out is the new professional roles. I prefer to talk about broadening competences. Integration requires to increase skills and to have the GP and the nurse as reference, to have the nurse in the hospital care, the internal physician as a reference as well. With regards to community health, there's a working group that has been made up by OSAKIDETZA and the health department, and more specifically with public health. And a methodological guide has been developed. A number of awareness actions have been developed, and also an action plan to have a community type approach. This is Osasun Eskola. It's the patient school to try and engage and involve patients so that patients are more active. And within Osasun Eskola, we have the active patient program. There's been 538 courses, and there's been 6,455 patients that have received training and 310 trainers. And I'm nearly finished. And then, to conclude, we have also a set of tools for assessment purposes, and we have the framework program or framework agreement, and the funding system with OSAKIDETZA, with the Basque Health Service. And within this framework, there's one item related to integrated care, and we have different sub-indicators. And if we look at the indicators since 2015, we see a positive trend. Last year, in a corporate manner, we used the GESPA. It's the patient experience assessment tool, and in one of the items, it's asked whether patients are coordinated. If professionals are coordinated, and in out of 5, we were at 3.5. With regards to the satisfaction survey, there's a new point within the survey, and it covers integration. So 0 to 100, and the is a global approach. So, and we rank at 6.58. So, on the other hand, we have two tools, which is called the love tool, the d'amour questionnaire, and the tool 1 out of 5, from 0 to 5, it would be at 3.61. And then we have the YEMAC, the chronicity care assessment model, and we would be at 62% out of 100. And that was it. Thank you very much.
Muchas gracias, Rosa.
Thank you, Rosa. Any questions? You've been very busy over the past 8 years, I would say. Hello, my name is Pedro Garcia. I'm a doctor at ER. In Santa Marina Hospital, we have people with chronic disease. Rosa, we've seen that over the 8 to 10 years, there's been a change in the structure, a professional and cultural change in our organization. In your opinion, what has been the most difficult to change? People, the structure in OSAKIDETZA, departments? What's been the biggest challenge? What's been the biggest obstacles? Well, people that make up OSAKIDETZA. This has meant a cultural change at the end of the day, and cultural changes cannot be reached overnight. It takes a long time. So what takes most effort is to change that mindset, to change that culture, to view things in a different manner. And I've already said that this biomedical model that we had is not completely inexisting now, but it's disappearing little by little. But viewing the patient in a different manner is very important. But we're all struggling in a way. But there are the people who believe in it, and I know that many people believe in this change. We go little by little, and we do make changes. Thank you very much. Any other question? My question is a bit the continuation of the previous question. There still needs to be work done, and the purpose of this conference is to learn. One of the purposes and experience of people who have worked in integrated care. What would you do different? So if you look at hindsight, so sometimes you can look back and say, well, it would be better if we hadn't done that. Well, now we have more the involvement of patients. Things are done not only for the patient but with the patient, and I'm talking in a holistic manner. And I think this is changing. And we are all learning. This is an ongoing task, and that it needs to involve all professionals, and that we all can contribute to this change. But first we have to believe in this. We are trying to make patients protagonists and professionals. Big hospitals and have been built for professionals and not sometimes for the well-being of patients. Thank you very much. Any other question? Thank you very much, Rosa, again. Second speaker is Marisa Merino from OSAKIDETZA, from the Basque Public Health Service, and she will talk about integrative care as a response to the challenges. And my name is Marisa Merino, and I'm from the Integrative Care Organization of Tolosaldea. Rosa has made a fantastic introduction so that you have a very good context. Our organization is part of OSAKIDETZA, is one of the 3 organizations. It's 20-minute drive from San Sebastian, from Donosti. And we are OSI since 2015. Aging, chronicity increase, make health services to look for new strategies to improve care. And in that aim, OSAKIDETZA in 2013 organized to create integrated health services, and in order to improve care for our patients. Ever since the IHS kicked in, we started to work on a framework agreement, and that has set the guides. So it's a populational-based approach, and with a very specific governance approach. And the idea is by combining the cultural change and the governance model, we want to have an integrated care productive interactions. So we have an annual program that is updated on a yearly basis, and that we use as a reference. All these, we all use the same agreement, the same framework agreement. So what did we do in our organization? We came to life in 2015, and we started to work with this framework. The idea was to improve integrated care of our population. We cover 66,000 people, which belong to 33 municipalities, and our aim was to have put the patient at the center and to focus on primary care and to get involved with all the stakeholders, and using an advanced management model. And that so the first thing we did, we identified the different stakeholders in our organization, and we built the strategic program with them. We set up groups, we involved them all, and we defined the mission: contribute to improve health in our population in an efficient, innovative, and safe manner to the benefit of society. Our values are patient, professionalism, teamwork, a sense of belonging, participation, which is key, and good governance. And by using an advanced management model, because we were using very similar models in the past. So, which is, we have an integrated management model, which is based on an advanced management model, like everywhere in OSAKIDETZA. We have 5 elements. Strategy. Strategy is very important to have contact with the stakeholders, and based on the initiatives of the stakeholders, we develop a strategic plan, and we deployed this or implemented this in the process. Customers, and we want a cross-sectional and longitudinal care, and promoting and health. With regards to professionals, we have a distributed leadership model. With regards to primary care services, these are distributed in order to favor communication. We wanted to have this distributed model. And then we have talent management. With regards to the social aspect, OSAKIDETZA is the biggest company in the Basque country, so we are the main driver of local economies. We need to favor this element, and it's very important. Transparency is very important, as well as sustainability. And then innovation. Innovation is fundamental. If we are to move forward, innovation plays a key role. Not only innovation as such, but we need to manage innovation and use the tools offered by technologies. We foster artificial intelligence projects that allow us to go to 5P, preventive, predictive, population-based, and we integrate resources or requests from other elements like certifications, ISOs, etc. The strategic approach, like any other organization, we are based on the health plan, and from there we build up the strategic lines, and we have the agreement on a yearly basis that sets the guides together with our strategic plan that we have drafted. So with this, we put this together and we have a strategic plan, and we disseminate this information to different areas and different services, and we have indicators as well. With regards to outcomes, we have an assessment of the framework agreement or framework program that has 9 pillars with over 200 indicators at all levels. Apart from approach, deployment and mid-term indicators and outcomes. Within these OSIS ranks, we are top performers. We started in 2015, but we've always had the best performance. Something else that was mentioned by Rosa was the survey on the perception of patients on integrated care. Colors represent our organization, and we already started off very well because in that area we had been working as in this field before becoming an integrated care service, but we're always above the OSAKIDETZA average. So this approach has allowed us to get very good outcomes, not only in terms of the contract, but in terms of other certifications. We have the quality certification, the OSHA's certificates, the RSCs, and we have a number of certificates. Now we are managing or applying for the innovation management certification, and this has allowed us to get certain recognitions, like for example the award for integrated care, the advanced management model Euskalit Silver, the the best project of digital health, the Health 2.0 Basque 2018, or the Quality Innovation Award that we won in Beijing. And then I would like to talk about the CareWell European project that was led from OSAKIDETZA, and we are mainly involved in all the project. I was the lead investigator. We received many awards at national and international level. The prize, the Elicit prize, we won the Elicit prize in Dublin. With this project, the European Commission published the fact that out of all the projects carried out over the past 11 years, CareWell, one of the top projects, because it was a multiple pathology integrated care project, and we are fully involved in this project. With regards to the approach and the management model, an integrated care service and combined with a good management model is worth it. It improves healthcare, it improves satisfaction of professionals and patients, as well as the sustainability of the healthcare system. The involvement of all stakeholders right from the beginning and assessing and validating the progress does have an impact on outcomes. And this is something that we should consider in the future. Leadership, clinical leadership and professional leadership is fundamental to implement these sort of models, and that we need, especially managers and area leaders, we need to have tools, we need to have knowledge that help us facilitate and make this work and to reach our goals in order to get to the integrated care. I did want to show you a video of our organization for you to watch.
Sí, sí. La Organización Sanitaria Integrada Tolosaldea está formada.
The integrated healthcare is made up of 5 primary care services and provides service to 66,000 users. We want to contribute to improve people's health in a safe, innovative, efficient manner. For this purpose, we are committed to integrated care, where the patient is at the center. We have 186 professionals. We integrate values like patient at the center, professionalism, teamwork, sense of belonging, participation, and good governance. In our management system, we promote continuous improvement in the advanced management model based on the strategies developed by the stakeholders. We develop the strategic plan that is developed depending on the process. Our target are customers that are stratified depending on the population. We work with outside partners to provide integrated, continuous and longitudinal care. We perform actions to promote health, and we have communication channels to manage our relationship with our customers. We share leadership. This commit our professionals. We take care of the healthcare of our professionals, and we manage talent. And we also ensure the rights, the language rights of the people. We are fully committed with the environmental and social sustainability, and we are committed with the ethics and transparency. We are one of the main drivers of local economy. Innovation helps us face current and future challenges. We would like to highlight the fact that we have participated at different European projects, and we have disseminated knowledge, and we have participated in digital health. The idea is to help professionals in the decision-making process. This has allowed us to achieve excellent outcomes, awards and certifications in safety, health and safety, and quality, social responsibility, environmental management, data protection, and smoke-free atmosphere or environment. We work for your health. Thank you very much. Questions? I'm going to check Slido, see if anyone... I have a question about digital transformation. That's one of the awards that you obtained, and congratulations for all your awards. What did you do in terms of digital transformation, and what did you do in that digital transformation? Well, we prioritize projects that use technologies that make our life easier, projects that lead to improved satisfaction of professionals and patients. The CareWell project, in all steps, we looked at the journey of the patient. We looked at the players which interacted with the patient, and we looked at which technologies could allow for better communication between the patients and professionals. And we considered this, and the award that we received in Beijing last month is because we developed a diabetes retinopathy screening software in order to improve patient care and the efficiency of our services. And now we are developing digital skills set for primary care professionals. The idea is to improve their knowledge and to improve and to direct training to these professionals so that they can develop further. Because right now there's a sustainability issue. And if we apply new technologies well, and if these are shown to be efficient, then I think that this is going to help us to be more sustainable. But we need to be rigorous, and by conducting an assessment. Within our philosophy, we want to work along those lines so that people can benefit from the good things of digital transformation, because whether we like it or not, there's the way forward. Thank you very much. Microphone, please. Hello, my name is Maider Mateos. Rosa knows me already. Marisa, I met her over the phone last week, but this question is for both. Integrated has been assessed in many parts, and you looked at people satisfaction, you looked at professional satisfaction, and you've mentioned some indicators. I don't know which indicators exactly, but what I was missing, and then this is my question, whether you've done this or not, or whether there are plans to do this. The aim of integration is to contribute to improve people's health. But have you measured that improvement of health? Have you been reduced of adverse events or admissions, or that you see that people have better health, or they monitor their pathology or through COPD, whether there's more health indicator that allows you to know whether there has a positive impact? Well, when I talked about the integrated healthcare framework, there's 9 pillars, but there are 9 dimensions, but over 200 indicators. And part of these indicators looks at how you deploy this. But I think there are 24 out of 100 depend on this. 64 would be what you are referring, and then there's another percentage that is for projects that could depend on organizations. We all share the same indicators. Most of the indicators are related to health outcomes. So historically, organizations always measure intermediary results or outcome, and these sort of assessments allows you to see the progress, but it also looks at final results. And we all measure the same things, and this allows us to compare among ourselves. I've given you the global ranking, but within the unit or within the health center, you know that if you're not performing well on a specific area, you know who's performing well, and that you can learn from these other people who are performing better, and or you can resort to other regions or other countries. So we are, compared to other regions, or we can say that we are better because you measure and you compare yourself. So all these indicators and is transferred to the centers every 4 months. We meet with other primary care centers, and we go indicator by indicator, and you go one by one, and depending on how you're performing, you have different improvement plans that are suggested by different organizations, because these are the people who work with the patient. So we not only have the disease type indicators, but we have community health indicators in order to promote health. So that's the way forward. In the integrated health framework, we look at the health outcomes. Last year, together with Deusto, we put up a framework. It's called the MORE tool. It's a web-based tool that way you can assess. And we validated this. And basically, it's a self-assessment whereby it allows you to know whether you are health-orientated or not. And when we did this self-assessment, we achieved a very good outcome. You always get things where you can improve, and this year we will see, whenever we do this self-assessment, we've done the things that we wanted. But just to confirm that, and this framework was not with OSAKIDETZA, but with other players. So we thought that the The framework in OSAKIDETZA was orientated to health, and the framework in OSAKIDETZA is very much geared towards health outcomes. The framework contract includes a number of indicators for certain pathologies, and there are OSAKIDETZA organizations that work with AICHOL. AICHOL has a number of health outcome indicators and patient experience indicators. Are these sufficient? Well, I believe not. I think that we ought to work more with health outcomes, and we have a project to try and continue working more with health outcome-based indicators, and it's a challenge. There's no doubt about that. It not only affects our region or our organization. I think that this is the case in many regions, and like the many organizations are working in terms of transparency. It's a challenge at a European level. So we need to get away from structure indicators or process indicators that have worked very well, but we need to focus more on health outcomes. And I agree with Rosa. We need to work on the patient experience. We are working with the ESPAC, but we are working with other things in OSAKIDETZA. We have a high satisfaction rate of the patients, and 99.25% out of 100 were very good, but we will be victims of our success. So we have started out to set up patients fora where we ask them what we ask patients to express what we can do. We've done a group with retired people, and they're very happy, and they asked us to do this in other age ranges, and they surprised us the fact that they like technologies, that elder people like to follow with phone calls. They want to use Skype because they want to see the doctor when they do these online consultations, and we received a great deal of information from them. So we are working very well, but we need to continue. In terms of quality of life, we have surveys and questionnaires on the website, and there are certain in certain processes and certain pathologies, things are being done. We need to continue working. We need to integrate it in one way or another, and we need to work with health-based outcomes. That's no doubt about it. Questions? Any? Okay, we got to the end. If not, we can always continue our discussion later. There are going to be many opportunities to meet. I would like to thank Rosa and Marisa, and I hope that you enjoy the rest of the conference, and I hope to see you again. All the presentations and the video will be available at the ISIC website. Thank you very much.
Okay, good afternoon. Everyone sit for the last one of the day. I'm David. I've been a GP. I've been the manager of the health insurance in Belgium. I'm now retired, grandfather, etc., etc., and a bit active and passionate by the team. We are going to talk about integration in primary care. We will see it from different angles and from different countries. And I would like to start immediately with Ilmo Keskimäki from Finland. He's a research professor, and you are going to introduce some your findings in regional integrated care for 2 counties in Finland. You have the floor, please. So we are going to take the questions at, you can send the questions through the Slido application, but we will have the discussion at the end. We have 5 presentations, and I'm going to try to keep you in the time so that we have some space left for questions and discussion. You have the floor.
Talking about care integration in Finland and in two regions, I think that these 2 examples I'm going to present now is rather ambitious way of trying to integrate services in health as well as social care. This is not entirely on primary health services, but also covering specialized care, hospital care, and so. As I said, ambitious way of trying to integrate services for people. So first some policy background facts on Finland. So as everywhere, there is an aging population. There is quite a lot of internal migration as well. There is a rural depopulation going on in Finland, and if you consider that we have public services which is based on municipal organizations, and municipals are arranging most of services in Finland for the people, that means that there are strained in the municipal's ability to organize these services. That's why there's been several attempts, unfortunately failed so far, to reform the health and social services and as well as regional administration. So even if they have failed, they have, let's say, described the landscape on the direction where to go. And there are certain principles. In most of these attempts to reform the services, there is recentralization, strengthened central stewardship. There is an attempt to create a larger health and social care organizers, or get out of the municipal base of these services, and move towards what is more like a Swedish type of healthcare organizations, so counties. And as well, there is a client-centeredness that is important. But there is different types of underlinings of how to achieve that integrated care, or some have proposed patient choice and competition. There's of course the idea that these the current system is not sustainable in financial terms, at least in the long run. So some basic facts about the social and health services in Finland. So there is public provided, they are publicly funded. The municipalities, as said, is organizing the services, and they are responsible for organizing both social, health, and specialized care. So, and also the municipal organizations are providing the services. That is important. So hospital services and specialized care services are organized by the hospital districts, which are federations of municipalities. Even if they are federations of municipalities, unfortunately, at least for municipalities and for primary care, they are very dominant by the professional strength, and they are political actors as well in their regional areas. So that's why challenging the cooperation between specialized care and primary and social services. Going to these local initiatives to develop integration. So, because there is a stalemate on the national reform, some regions have started to establish new collaboration and trying to make their own reforms in the health and social services. In fact, 8 regions in Finland are so far established this kind of joint authority for organizing all social and health services in Finland. Most of them, or 6, is really recent, so established last year or this year. Altogether, they are representing about 20% of the Finnish population, so they are not really a small-scale trials, but really major attempts. Then it's in fact, what has happened is that these municipal federations running hospital services have assumed new tasks, but also they have reorganized their functions quite comprehensively. And for instance, I can show you an example. This is an example of one of these reorganized joint authorities, which is running the health and social services. So there is the same services as they used to be in municipal organizations and hospital district organizations, but they are arranged in a different order. So according to the key clients and according to their needs. So there is family and social services which are providing psychosocial care, promotional activities, health promotion activities for kids and families. There is health service and elderly care, which is providing curative care, but particularly focusing on services old people are needing. So the chronic conditions. And then what is third compound, this is rehabilitation, which is really showing a new thinking. There is lots of strengthening of the rehabilitation and taking that into the new form, also increasing the resources for rehabilitation. So what we are doing is to really run case studies on these 2, let's say, a little bit earlier initiatives, and very intensive case studies, collecting material, documents, reports, but also interviewing managers, supervisors in these services, as well as employees, in order to consider the outcomes and assess the outcomes of the service of the reorganizations, as well as considering issues like how well this can be transferred to other contexts. At the moment, we don't have possibilities to present all the services here. We give 2 examples. One is coming from the services for children and young people, and how they are reorganized. So there is, in one of the areas that is EXO, there is South Karelia Health and Social Care District, they have formed a new unit for services for children and young people, which are combining the services from schools, from hospitals, primary health care and social services, and put that together in one unit, which are operating on walk-in principle. That means that there is no need for referrals. The families or the client is coming in, and then based on interview, it is decided who are the professionals needed for the care of this patient or client. So this is the principles of the service unit. And if we consider the outcomes, they are positive. The service processes have become quite seamless. There is easy access to consultations to specialists because they are working in the same units. There are indications of cost savings, the decrease of very expensive care forms like taking place in the institutions, social protection, child protection institutions, psychiatric care in hospitals, and so forth. What is challenging is that how to organize these services in rural areas. Then, sorry, I skipped the slide. So then there is second example. That's coming from elderly care. There is 2 very important features in the services. One is that the focus is on home care and rehabilitation. So many of the services which have been taking place in clinics, like rehabilitation services, are taking place at homes of the old people at the moment, and also even a part of the emergency services earlier provided by the hospitals have moved in to patients' home. So there is a mobile acute care unit which can be called to home by the home care worker if that is needed. The home care, and then there are new service forms which are really strengthening these approaches. That is, there are walk-in advice centers. There is strengthened case management, strengthened discharge management, and which are helping to reformulate the service principles of the whole elderly care. And if we consider the outcomes and assessment, particularly the mobile care, acute care, is forming a positive experiences. So the home care workers, as I said, they have possibilities easy possibilities to consult GPs, as well as call the paramedics to help if the condition of the patient is needing that kind of interventions. So what has happened is that in fact the care in emergency services as well as in hospitals have reduced. So there is indication of efficiency. Then what is challenging is that it's even in this new form, there is a quite heavy workload for the home care workers. In fact, they don't have possibilities, they don't have time for rehabilitation, which is expected from them. And that is really undermining the new model. Then some conclusions. So, according to our estimate, our assessment, this has been a success story. The unified management works quite well, which is unexpected because this has been a battlefield of professions, or the management has been a battlefield of professions in Finland. The management has assumed the new values, new goals quite easily. There is really a system change in thinking from organizational and professional approaches to clients' needs. There is really a shared understanding of professional paradigms. Then, if we consider challenges, transferability, a big question mark. This is really based on a Finnish system, strong local government. There is public funding, public service provision. Is it possible to transfer to other countries? There is a need for adaptation. Anyhow, as I mentioned, it has been very transferable in Finland, within Finland. That is has been assumed already by other regions. Then, what is often undermined is the management. There is also need for everyday shop floor level management in order to run the services also in practice, and that is probably one of these aspects which haven't yet succeeded. Okay.
Okay, thank you. Just to clarify, could you just add what made the change coming through, so that municipalities got together, that they created these integrated organizations, and that all these innovative ideas came on the surface?
So there's been a kind of one area which has been innovative, which really started to work already 10 years ago. And they had, as far as I understand, they had challenges with how to organize the services at that area, because they are a rural area. There is, as I said, people are moving out from the rural municipalities, and how these municipalities, they are not coping anymore. They are not able to coping anymore in producing services. They need something. And on the other hand, the integration is not a new thing in Finland. That's been a general, let's say, policy, but not really implemented for a long time. They started to implement that, and it's so.
Is it a bottom-up happening?
Yes. In fact, on the other hand, as I said, there's been an idea to reform the Finnish healthcare system, but that's been politically very difficult, and that hasn't succeeded. So some of the areas waited long enough, and then they started to do something.
Okay, thank you. Thank you for the presentation. We have to move on, and we are moving to Canada. Yes, thank you. To Toronto. So this is a double presentation from Jocelyn Charles and from Pauline Pariser. And you're going to talk about designing primary care, right?
Yes, we are.
Okay, you have the floor.
So Pauline and I are family physicians from Toronto. And as we've just heard in our plenary talks this afternoon, primary care is foundational to an integrated system, but there's actually no recipe book to design it. We want to tell you a little bit about Central Toronto, and then Pauline's going to tell you about our primary care strategy. So the central part of Toronto has 1.2 million people. There are 17 acute hospitals, as well as specialized and chronic care hospitals. And some of our acute care hospitals have highly specialized care and serve the entire province. And we also have serve regional populations. There are 1,300 family physicians, but they're mostly unorganized. They're in solo by themselves or in groups. Some have some nurses or nurse practitioners, but they have all different payment mechanisms. And we've realized that we need a better integrated primary care system in order to integrate with the bigger system. So Pauline's going to share a little bit about our co-design.
Thank you, Jocelyn. This is a bottom-up approach in that we really felt that we were going to meet the needs of our local physicians, and we really had to engage them early on in designing the system and using data and analytics to understand the population needs at the local level, having various levels of engagement both locally and regionally with a range of providers and delivery partners. And very importantly, our local health authority was extremely generous in providing the local infrastructure, which meant each sub-region had a primary care lead. I was the one for downtown Toronto with a project management team and a local governance structure, which really allowed active involvement of the physicians in our neighborhoods. And as well as that, we would meet with the local community providers and hospitals to make sure we were aligning with the rest of the system. Jocelyn will talk to you about how we worked with our academic partners to identify population gaps and building on what we heard from the frontline physicians and those demographics, investing wisely on where we could start to co-design the system and develop new programs. And of course, using metrics to continue to monitor our progress. So the underlying premise, of course, is that those who know the system best, know what needs to be changed, are the ones that we need to consult, and that they really need the supports and resources to facilitate the change. So the primary care clinical leads worked with a local hospital resource partner, and we set up these primary and community care committees that brought those range of providers to sit on those committees to really participate very actively in designing and implementing new initiatives. We started with a real disadvantage. Our Ontario Medical Association was in fractious conversation with the government. We had not had a physician service agreement, and they actively campaigned with their membership to stay away from the health authority, who were seen as an arm of the government. But we persisted. We felt that as long as we could show that we were making good on our deliverables, that eventually we would start to see a groundswell of support, and that's in fact what happened. We had structured engagement opportunities around key services. We offered a continued medical education. Each sub-region sent out a newsletter. We even went door to door and called and got emails and made sure that we let people know what were some of the services and programs that were being rolled out in their local neighborhoods. We used surveys, and then we eventually had providers actively involved in our advisory committees. Eventually, the engagement spread to involve a range of local health system providers, the community care providers, as well as patients and caregivers. So this continuum is basically, it's based on the International Association for Public Participation, that you may be well aware of. And of course, we needed to start with those who really had not much to do with primary care integration with the local health authority, and just get their attention by reaching out to them, making sure we had their emails or we had their addresses, because some of them still rely on snail mail, and then moving to maintaining their attention. So giving them platforms that they can inform the initiatives that we were rolling out, that we could consult with them to make sure that we were course correcting if it did not meet their needs, and then moving to a higher order, maintaining their engagement by actively involving them in actual planning and implementation, with a smaller amount involved in decision-making bodies and being empowered. So these broad-based consultations involved patients and providers to really look at where were the population health needs and how would we best address them. There was an overarching mission, which was to co-design and deliver an integrated, coordinated, person-centered primary health care system, a tall order, but we were all very committed to it. The goals under that system were improved access to a range of sectors: primary care, interprofessional care, because there was real inequity as to who had access to team-based care and who didn't, and specialist care. Improved service integration so that primary care was integrating with other parts of the sectors, and increased system efficiency so that there were improved care transitions when patients left the hospital, and also that we were enhancing the use of digital connections. With the data and with the voices from the front line, we determined that there were 5 priority projects to focus on: attaching patients who didn't have primary care providers, improving the access for many more physicians to interprofessional teams, improving wait times and access to specialist consultations, making sure family physicians had what they needed when patients left hospital in terms of transitions in care and discharge planning, and onboarding physicians to secure communications so that they could really engage within the circle of care. So I'll turn it back to Jocelyn to talk about the data.
Thanks, Pauline. We realized that having data was incredibly important, not only to engage our primary care providers and our community providers, but to keep them engaged. Data would help us have a language to understand where we needed to work and how we needed to do it. So we used data from multiple databases on population needs, looking at provider characteristics, and it was one of the hardest databases to get was actually our primary care provider database. What are the health system delivery, looking at hospitals, their utilization, physician billing, public health, and city data, so many data sources. We actually worked with the University of Ottawa to develop an interactive tool to forecast health human resource needs, and so we've got a nice robust model that we're going to be able to use moving forward, recognizing that there are many changing factors that affect your health human resource needs, so we feel confident in that moving forward. And then we also did some very detailed geographic mapping right down to the neighborhood level to look at population needs on a variety of characteristics. And this was going to allow us to very specifically target our interventions. I'm going to show you a couple of examples. So this is maybe a little bit hard to read, but these are maps of central Toronto and our 5 subregions and our 77 neighborhoods. And you can see that in this map here, you've got, we've looked at the folks with the lowest income, and in the purple and green dots are our comprehensive primary care teams. So you can see that where the lower income areas are and where the teams are don't always match. And this is partly due to the evolution of Toronto over time. The map next door is a map of the use of interprofessional teams and the highest SAMI scores. SAMI scores are scores of patients, their utilization of primary care based on their chronic disease burden. As you can see, again, there's not a match of their high SAMI scores and where the teams are. So we wanted to use this kind of data mapping to be able to understand when we did put 5 new teams in, we actually targeted them to those green and pale areas of lower income and higher chronic disease burden, so very specifically targeted. So, as Pauline mentioned, we really needed to make sure that our local leaders could come together and provide an infrastructure to support primary care, the change that needed to happen, and also to implement the targeted investments. So during the first year, we put together with agreements with our hospital resource partners, as Pauline mentioned, in each of the 5 subregions, we had a primary care clinical lead, a primary care manager, we had a project manager, and we had a manager for the most complex patients. And we also looked at developing some of those priority projects across all 5 subregions. As I mentioned, we partnered with local academics, so some of our University of Toronto colleagues were the ones that help us get this very detailed data. And this regional support structure really allows us to use the data to target the funding, to put in performance management and develop annual work plans so that we can regularly report on our work. I think the most important thing here is, as we've seen in many presentations, the growing demand for care, the shrinking resources available, so we're going to have to invest wisely. So we've had some considerable investments and created lots of momentum, but we've had a change in government, and that continued investment is likely going to drop. So we need to really move to co-designing, building on existing resources so that we're optimizing the funds that are being put into healthcare. And I think it's important that we have a way of reviewing annually what we have invested in, what have we achieved from it through a very careful evaluation so that we can either tweak or look at where do we need new investments. So some of those include developing a primary care database, which we never had before. HealthLinks is a way of providers working together around the most complex patients. Pauline did a workshop this morning on SCOPE, Schemaless Care, Optimizing the Patient Experience, where family physicians have one number to call to speak to a nurse navigator, a home care coordinator, a general internist, or a radiologist to be able to access care in a timely way to avoid using the emergency department. And then we have other ways like SPIN and TIP that allow family doctors to tap into some of this team-based care on a just as needed basis. We've invested in some new interprofessional teams based on already existing resources. We're really working hard on digital care around e-consult, e-notification, connecting providers through the system, so no matter where you go in the system, your provider has access to the care that you've been receiving. We also have local healthcare connectors which attach unattached patients. And then looking at system integration, so making sure that our primary care is part of this complex system, and that although our system is changing, that through technological advancements and resource investments, providers are able to meet the needs of their patients, and that they're making sure that primary care is playing a key role in the evolution and adaptation of our health system, because we are the ones that are cheaper. So we have to be an integral part of that system. And so embedding care coordination in primary care, expanding palliative care, these are some of the things that are going to enable us to be more effective. And of course, having a monitoring system that allows us to measure what we've done. We're constantly looking at new metrics. We've developed a dashboard, and so that we can obtain results on an ongoing basis. Here's a picture of our dashboard, looking at all the projects that we're doing. Green is good, yellow's okay, red, we got to find out what's not working there and figure out how to make it better. And then looking at what are the key transferable learnings from this. So there are many elements that are transferable to assist other health systems facing these challenges. I would say, as Pauline talked about the approach to engagement, we have to engage our patients and our providers in building the system. And looking at, through these difficult transitions, how do we strengthen communication and coordination? What are some of the successful approaches to spread and scale of already existing successful, promising local initiatives? We're a bit tired of piloting. We need to take our pilots and spread and scale. How do we get better uptake of digital tools? And how do we make sure that we're always using a robust data analysis framework to inform our care? So thank you.
So this was, I think, it's a study on a larger scale than in Finland. We were talking about 1 million population there. And what you explained was some kind of, I think, a very thoughtful change management long-standing change management process. Co-design, engagement were words I heard, but also some kind of combating with the political authorities about resources. I think quite a lot is recognizable. Thank you so much for the presentation. We are now coming to the Basque County. Susana Pablo will talk, and if I was reading your abstract and I felt a bit like, why the hell don't they take health promotion? Is that right? That's the point you are going to make. Okay, you have the floor.
For coming and for your invitation to this conference. We are delighted to share with you the results and to discuss with you our main conclusions. So thank you very much. The aim of this scoping review has been to identify and to describe implementation strategies used to integrate health promotion interventions into primary care and community settings. If health promotion is so important, because we think that health promotion is the most important clinical intervention, why is not systematically integrated into primary care and community settings? We don't understand. As we all know, one of the most serious problems nowadays is the increasing burden of chronic diseases. Chronic diseases are responsible for almost 70% of all deaths worldwide. And most of them can be prevented because they are related to factors that we can modify. Poor diet, low physical activity, smoking, and alcohol are some of them. We have a very serious health problem, that's true, but we have good news, because on the one hand, we have several clinical interventions that we know that are effective. On the other hand, the most prestigious organizations recognize the important role of primary healthcare professionals in the delivering of health promotion interventions. But the reality is that health promotion is not systematically integrated into primary care and community settings. Here, we can read in a recent publication that in the USA, only 8% of adults receive an appropriate preventive service. And this is a common trend in other healthcare systems. So, what happens? What's wrong? We have a very serious health problem, but we know what to do to prevent it. And we also know where to act into primary care organizations. But the reality is that health promotion cannot be systematically adopted in a standard and routine clinical practice because there are different barriers operating at different levels that make the translation very difficult. So, in fact, we have an implementation problem. If you realize, we have changed the focus of our presentation. Because we started saying that we have a clinical problem. We said that we have a very serious health problem. But in reality, we have another kind of problem. This is an implementation problem. And this means that we know what to do to prevent chronic diseases. But the problem is that we don't know how to do it. So we need to open the implementation toolkit. We need to use and to apply the theories and the methods of implementation science. And in particular, we need to design, to apply, and to evaluate implementation strategies. Implementation strategies are methods and techniques that we can use to increase the adoption, the sustainability, the dissemination, and the scaling up of those clinical interventions that we know that are effective, as is the case of health promotion interventions. Our motivation to conduct this scoping review is that we wanted to learn more about implementation experience, about how to integrate health promotion interventions into primary care and community organizations. In this sense, a scoping review has been a very useful design because on the one hand, conducting a scoping review has allowed us to acquire a general overview of the topic. On the other hand, the scoping review has also allowed us to detect the most emergent research questions. In our scoping review, we have conducted a systematic search of implementation projects with 5 components. The first component is that we need implementation projects with an implementation strategy. The second component is that this implementation strategy is used to integrate a health promotion intervention. The third component is the health promotion intervention is addressed to modify at least one risk habits: poor diet, low physical activity, smoking, and alcohol. The fourth component is that the clinical intervention in health promotion is delivered into a primary care organization. And the last component is that we require that implementation strategy needs to have been evaluated. In this scoping review, we have formulated 3 research questions. The first one is that we want to know how many projects have these 5 components. The second question is that we want to know which kind of implementation strategies were the most frequently used to address this translation gap. And the last question is about the quality of specification and reporting of implementation strategies. In this scoping review, we have applied the standard methodology used in bibliographic reviews. And here you can see the main steps that we have followed. So we start with our first question: how many projects? After removing duplicates, we had 1,641 studies. And after applying the inclusion criteria, we finished with 45 studies that we regrouped into 35 implementation projects. The majority of them were published in the USA, and after 2006. 2006 is an important year in the history of implementation science, because in that year, Eccles and Meitman provided the definition of implementation research in healthcare. Our second question is about the kind of implementation strategies used. In the left area of the slide, you can see that the majority of the projects combine different components in their implementation strategies. And those published after 2010 design more complex implementation strategies, combining different components in the strategy to simultaneously address different barriers located at different levels. In the right area of the slide, you can see that the most frequently used implementation strategies were passive, as for example, training and education, and audit and feedback. These strategies were used to modify individual characteristics of healthcare professionals, as for example, to increase their knowledge or to modify their attitudes or beliefs about health promotion. In this slide, you can see how each implementation project, remember we have 35, combine the different components in their implementation strategies to integrate health promotion interventions. I suppose that you can appreciate a predominant use of violet and pink colors, and they correspond respectively with training and audit and feedback strategies. Our last point is about specification and reporting. And in general, we can say that the quality of specification and reporting of implementation strategies was very low. We have here some examples. The first one is related about actors. It's true that the majority of implementation projects mention the actors involved in the implementation process. However, they didn't clarify how these actors interact and cooperate among them. The second example is about temporality, and we have found that only 51% of projects reported this information, and we understand that knowing the implementation length is a very useful information. The last example is about the use of theories and theoretical frameworks, and we have only 6 implementation projects in our scoping review that use an implementation framework to design the implementation strategy. The poor quality of specification and reporting is a very serious problem because it make very difficult the replication of the implementation project in other settings and the generalization of the conclusions. And as we all know, replication and generalization are two important processes for scientific communities. We are arriving at the end of our presentation and we have 3 conclusions and 1 recommendation. The first conclusion is that we have only identified 35 implementation projects, only 35 in the world. The second conclusion is that the majority of the implementation projects design passive strategies addressed to modify individual characteristics of healthcare professionals. In other words, only a minority of the projects design an implementation strategy to modify structural characteristics of inner and other settings. The last point is that the poor quality of specification and reporting, the weak use of theory, and the moderate quality of evaluation have made very difficult replication and generalization. So we strongly recommend the use of the study guidelines because it is helpful to improve the quality of specification and reporting. And it is essential to have a good design of an implementation strategy to improve the quality of primary care service and also to reduce the burden of chronic diseases. Thank you very much for your attention. And we have a last reflection. So if we continue to do the same things as always, it's difficult of time change. So thank you very much.
Thank you, Susanna. One question. What is the Basque Health Service now going to do? Having done this research?
I have the answer. We have a team of experts in implementation research, so we are trying to design implementation strategies to scaling up a program, the Prescribing for a Healthy Life program, to the World Organization. So our aim, the aim of my team, is to design an implementation strategy to improve the quality of service.
So that at the end you don't have any more to say, why the hell don't they?
We hope.
You hope so. Thank you. I'm now giving the floor to Dr. Alan Williams from Wales, UK. And this will be, I think, also a very specific story because it's about what are you doing if you have no more or almost no more GPs available and the effects of that situation. You have the floor. Okay. I hope I cited correctly your abstract.
That's fine. Thank you very much. My name is Arvan Williams. I'm a general practitioner in Nevin in North Wales. I'm not an academic, as you're about to find out. 4 years ago, I was left as the last GP, the last man standing to care for a practice of about 4,200 patients in a very rural area. This is our town, just there. Right on the west and northwest tip of Wales. We're closer to Ireland than we are to England. So we were in a bit of a pickle, really. We all know there's not going to be a busload of GPs coming down the road anytime soon. So we needed to work differently. We needed to come up with a plan, and we needed to do it really very quickly. I had 3 months to try and sort it out. So it was a difficult time. What I'm going to tell you about today is based on about 100,000 consultations. It's not rocket science. It doesn't make you the best doctor in the world, but it kind of gives you a fighting chance of doing your job with some kind of success. Robert Peston is a political journalist in the UK, has his own TV programme. This is one of his tweets from the other day. It's a big problem in the UK, and talking to a few of you from all over the world, it seems to be a bit of a problem everywhere, really. So, just to give you a little bit of background, in the good old days, there were 3.5 GPs in my practice. I was one of them. We were looking after about just over 4,000 patients. We work in a very rural area, as I said. This, to give you some idea, I'll come back to this slide in a second. This is our practice area outlined in red, and from one end here to there is about 60 kilometres. It's about the size of London, or from San Sebastian to Biarritz, so it's quite a big area. And all our patients are supposed to be in that red line, but they've kind of escaped, and they're kind of getting further apart, so that's another issue that we're having to cope with. We've also got some beds in a community hospital, and we've got quite an elderly population. People like to come retire where we live because it's quite a nice place to live. The surrounding area, that big triangle I was showing you, has a GP to patient ratio of 1 in 3,500, which is not good. Ours is 1 in 4,500, which is even worse. But hey-ho. So, that's our area. There's 5 practices in that kind of area, but we're just one of them. Maybe when you were at school, your parents told you if you work hard, you can be the best. And there used to be a programme in the UK, it's stopped now, sadly, called Top of the Pops. I used to love watching it every Thursday night. I used to dream of being top of the charts. And this lad here is actually my son. He's got his dad's good looks, you can tell. He's actually made it to be quite a successful performer. Anyway, I wanted to be top of the pops, and I finally made the grade. He probably passed you by, all of you. You probably would have missed this one. I got the dubious honour of being the #1 practice most likely to fail in North Wales. But you know, all publicity is good publicity. So we had a problem. So we needed to do something pretty quick. And we started with the premise that people just want their problems dealt with promptly. It's quite a simple thing to base your work ethic on. So this is where we started from. And then this is what we did, essentially. And we had to do it very quickly. We had a chat with my staff. They were very good, they were excellent, they were very keen to work. There's not much employment around where we are, it's very rural, so to be fair, they've been really supportive. And what we've tried to do is upskill every member of staff that works in our organisation. There's about 17, 18 people who work for me, or with me, and every one of them is expected to take on new skills. So the receptionists no longer just answer the phone, they triage and signpost every single phone call that comes into the practice. We had to replace the retiring GP. I didn't tell you why we ended up with just me. Very sad. One of my colleagues was killed in a car crash. And, well, a couple of years later, the remaining 2 GPs retired together. They kind of jumped ship together. It was kind of a pretty cool decision on their behalf, not so good for me. So all the staff have been, oh my word, sorry. Technology in me is another thing that we don't get on. So all the staff can put ECG machines on, blood pressure monitors, they can use the CRP machine, they've been trained in triage, some of them have been trained in dispensing, 2 of them work with the practice manager 1 day a week to upskill themselves doing admin, payroll, all that type of thing. So we strongly advocate that people get as good as they possibly can, and it's good because people, their self-esteem improves, their self-worth. So our staff turnover is very, very low. It's 0 really. So they've been taught to signpost and triage every call. So gone are the days that you can just ring the doctor and I want to see the doctor, please, and you just get a GP appointment. That doesn't happen in our practice anymore. It's just simply because there's only me. So we had to kind of, we basically ask patients what's the nature of their problem, and then they will 99% of the time volunteer what the problem is. Most people are quite happy to put on Facebook what their ailments are, so telling the surgery is no big deal. So the vast majority do. The very few that refuse get a call back from me if it's a personal problem. Some people were quite savvy at the beginning and worked out that if they didn't tell us the reason, they'd get a GP appointment, so we kind of stopped doing that. We have a 1 phone call rule. So if you've got to answer the phone after by the 3rd ring, we don't let it ring for ages. It just causes anxiety for people. So we try our very best to sort out your query in that phone call. Sounds simple, but if you want to come and see me a week on Thursday, we'll try our best to do that. If that's your only day off, we will try and accommodate you. So there's no point saying ringing me back tomorrow, ring me back in the morning, because basically you're just transferring today's work onto tomorrow, and by the end of the week you're just snowed under. So we have a few rules. there's a lot of My Health Online, it's called in Wales. I suppose you have it all over the world, where you're allowed to book appointments to see a doctor online. You're not allowed to do that with us because we can't triage what's wrong with you, and we can't decide. The whole point of this signposting is that we have to decide, or the receptionist has to decide who you need to see. It might be the physio, it might be the audiologist, it might be me, it might be the advanced nurse practitioner, it might be mental health, but it's really trying to take me out of the initial triaging consultation, part of the equation, really. So the girls do that. They are girls. They're there's no men working for us at the moment. I don't know why that is. So this is very important because the practice next door to us allow it online, and then by the time staff come in at 8 o'clock in the morning, all the appointments are gone, and they've got nothing to offer all day, and everybody gets really upset. At the beginning, communication with our patients was absolutely essential. Because of where we are the only show in town, really. The nearest practice is about 10 miles away. And they're also struggling as well. So we told them what we were doing right from the outset. There's no point. You've got to take them with you. And to be fair, they've been very supportive. And it's a two-way thing, because I'll get to the results in a second, but they actually get seen on the day, or, at a time that suits them. So most people are pretty happy with that. And all our staff go on training. We're big on training. So this is where we are now. Our practice, where it used to be 3.5 GPs, is just 1 GP and 1 advanced nurse practitioner. They're both very experienced. They've been around. They're very, very good. And they prescribe, they refer, they do everything. So on any given day, miraculously, we've managed to get 15% of unfilled appointments to see me or any senior clinician. There's always slack in the system, which is good, because it means that I'm not having to see extras all the time, and patients are not getting turned away. So capacity equals happy, satisfied patients, we've learnt, and problems are dealt with promptly. There is no waiting time to see us, and the staff are pretty relaxed as well, because they've always got something up their sleeve. If somebody really does need to see me at 5 o'clock, there's probably still a slot available. So the workload is pretty manageable. In case you think I'm sending everybody to the emergency department, I'm not. We've got very good levels of not using secondary care, be it unscheduled or scheduled. We've got low antibiotic prescribing, lower than our health board average. And AstroPU, I don't know if you use that. Do you know what AstroPU is? It's like a age, sex, weighted costing system for looking after patients. So ours is pretty low. It's lower than, can't get this thing to work. That's the Welsh average, and we're down here. Interestingly and controversially, ours is about the same as the average in England, and that's because you get free prescriptions in Wales. So you don't pay for your medication. Even I don't pay for my medication in Wales, which is a pretty crazy system, I think, bearing in mind the austerity. So our AstroPU is quite high, bearing in mind the UK average, but that's for another day probably. The average number of consultations face-to-face offered in the UK varies widely, from about 7,000 per 1,000 patients to about 3,000. I don't know what these fellas are doing, because we're not seeing that many, but that's about as low as we can safely get it, and everybody be happy, really. So the other side of that is that we deal with it in different ways. So originally, when we started doing this scheme, I was seeing about 60%, just a bit more, GP and AMP consultations, and this is the nurse one. So she's started seeing more of them, and I'm seeing less, which is good for me. But I'm always around for a second opinion, so it's not as if I'm not, not there. This is, as my staff get more experienced at knowing who needs to see what, then these dynamics will change. So presumably, hopefully, they will cross sometime soon, which is controversial as well, but there you go. So originally, we were dealing with about 1,500 patients per 1,000 patients on the phone or by email or whatever, and that's gone up now to about 2,000, as you'd expect. The kind of message is you don't have to see everything face-to-face. Some things can be dealt with. I was speaking to a colleague earlier, and she was telling me she doesn't really want to go to the doctors if she can help it, if you can be sorted like pill checks and stuff over the phone, whatever it might be. Anyway, so we have a few rules. We like to clear our desks. We don't encourage you to leave any work for anybody else. Sounds simple, but you know, it works. We're always changing. We're not too proud of our little baby. We're always fine-tuning. Sign up to a few things like batch prescribing. We only sign one prescription every 6 months for people on chronic medication. I'm big on supporting my staff. If you're nasty to my staff, you get me ringing you up and sending you rude letters, so it doesn't happen much anymore. And we delegate, so I have had to delegate. It was that or give up. I was asked to hand back the keys for my practice not so long, you know, when all this started, and I refused to. And but you've always got to be there. You've got to have an open door policy and be ready to give your opinion and support your staff, and be awkward, you know. Yeah, can it be scaled up? I very much think so. It doesn't matter if you've got a huge practice of, say, 20, 25,000, or if you've got a small one like ours. It doesn't really matter. It's the principle that matters. So, yeah, thank you very much.
Thank you so much for this story, very interesting. Makes me think, for instance, in Belgium, actually, there is quite a lot of concern of the dropping number of general practitioners, so there's also some aging going on. And then there is a big concern because people have to look a bit further on. If we here, we should push them to get still lower and then have these ideas of how better organizing practices. There's quite a lot of room of improvement. It made me at a certain point think of what we heard in the plenary about the WHO, who says that we have about 40% of waste in the system. Well, these are examples, I think, of setting down better care, but also in the quadruple aim logic of being also with welfare for the providers themselves. And this is important. So thank you for having brought this forward. We are moving to the last paper presentation and moving to Poland. Katarzyna Wiktorczak, Kasia, you are going to talk about primary health care plus project in Poland, and you are project manager at the National Health Fund in Poland, which is the health insurance institution for the Polish people. You have the floor.
Thank you very much. Probably my presentation will be the last in today, so I really appreciate that you're here and want to listen. How it was told, I work in the National Health Fund, and what I would like to show you is our last project, primary healthcare pilot program for the primary care doctors from the biggest team, because now in Poland the basic primary care it's sometimes only GP, sometimes it's GP plus midwife plus nurse, but they work very often separately, and when the patient comes to the primary care, if would like to continue the healthcare service, just get the referral to the specialist, and of course have to wait for the another visit in different part of the system, because we as a National Health Fund, we contracted also separately with different part of the healthcare market, because we have separate contracted with the GPs, separate with the specialists, and also separate with the hospital. So a few years ago, we started thinking about the coordination, and we've got a lot of discuss what we should to coordinate it, and what should be the first stage. We thought that the best option is it will be start from the beginning, from the place when the patient comes for the first time. So we added to this basic primary care two very important components. First is the preventive checkups, and I would like to describe this part, and also the disease management element for the patient with the chronic disease. Because how we observe in the whole country and also in Europe that the citizens goes older and older, and a lot of them have chronic disease. So we need something different mechanism for them. And I can say that this pilot is a little bit bottom up. It's a variation from bottom up because we discuss with the providers when we when we were planning this project, but this is organized and financed by us and also by from the European funds. The project started in July 2018, and now we've got the information from the Ministry of Health that we could extend this project till December 2021. We organized this project in the whole country, and this is good and this is bad, because probably it will be better if we could concentrate this pilot in one region of Poland. But in European papers was written that we have to do it in every regional, in the voivodeship. So this is how we have to do it, and we do. The providers cover more than 300,000 patients in their clinics. So this I think it's not small, but a medium pilot program. And for whom is the checkups? First of all, for the patients who comes to the primary care, but especially for people between 20 and 65 years old. In the best cases, when the patient didn't use the healthcare service in the last 12 months. So we try to find the people who didn't use the healthcare service, and we try to convince the providers that they should to start to stratify their populations and get the knowledge about who and how the condition is of the patient which they covered. And how the paths of the checkups looks. First of all, the team of the primary health care should be very engaged, because they have to first qualify and then recruit the patients. So they have to do it actively, should to call them and invite to the visit. The patient should sign the consent. If he or she didn't do it, this is the end of this program for him or her. And then we can divide these checkups into two parts. First is a basic for everybody, and in these basic checkups we offer the set of 5 main popular diagnostic tests. It's morphology, ESR, urine glucosis, and lipidogram, and this is the set offered for everyone. And then the doctor, sometimes the nurse could start, but the doctor finish the questionnaire balance. I skipped to another slide to show you what's inside this questionnaire. And what is the main idea is to fulfill this questionnaire together with the patient. There's a lot of questions, but we want to collect the information not only about the condition, but also about the previous health history, about the participation in the screening programs, preventive programs, because we as the National Health Fund offer a lot of them, but only 5–7% use these programs. In this questionnaire, the doctor or nurse should collect information about the medicine, about vaccinations, about the family story. I mean, family story, it's, for example, the chronic disease in the closest family members. And after fulfilling this questionnaire and after the physical examination, the doctor decided this is the end of this checkup, and send the patient, okay, you can come after 5 or 3 years, everything is okay with you and you've got the status 1. Or if the doctor recognized some risk factor, could refer him to the extra diagnostic, and this is what is different between what is now in the basic primary care in this project, that if the GP referral the patient from the program to the specialist, this is the team of this primary care GP, because we pay directly to the GP and GP pay to the specialist. So the patient a little bit skip the clue, because the GP work closely together with this specialist who's he hired. Of course, the result should be in the electronic version, and the specialist and the GP and the team of this primary care should exchange the data from the patient for preparing the patient summary. This is something new, because how I mentioned before, when the patient comes to the GP now, it's probably the one contact and then move to the specialist. Now, when we GP prepare to the patient summary and the plan for the next visit, next educational part, the patient knows exactly what to do in the future. And this is also the small element of the management of healthcare by the patient. I mentioned that also after the checkups, the doctor decided what kind of status has the patient. So we propose 4 status. First is healthy, no risk factor, so you are really healthy and nothing happened with you. But sometimes if you have maybe a little bit BMI, the GP could send you to the educational visit. So you are the status 1, but still you can use the extra offer from the educational packet. The second status is healthy, with some risk factors. 3, it's chronical ill but stable, could be conducted by the GP. 4, it's chronical ill, requiring the stabilization. So sometimes it might be done on the primary care level, but sometimes the patient should go to the specialist and also skip the program. Okay. Maybe I should emphasize that the educational visits are very, it's something new here, because I can say that it's a set of the visits, because after the checkups, the patient come to the healthcare educator, and after 3 and 6 months, he will come to the supervising educational visits. So somebody plan for the patients what he or she should do, but after 3 or 6 months, it's checked that the patient do what he should do. And here, this is the example of fulfilling questionnaire, just to show what the patient get. And what is also new and important, that after printing this patient summary, the patient should sign that he agreed with this plan and try to do it. And we also started to monitoring the results. We just beginning this pilot because first agreement with the providers in the project was signed in July 2018. But till the end of 2018, 8,300 extended checkups were done, and also 1,700 basic checkups were done. So we are in the beginning. I hope that we conduct new components for the primary health care, and probably on the next IFIC conference, I could say more what was the result, and we also will have the survey what the patients think about this new solution, and they agreed that it's something important and useful for them, or they like the previous system. Okay. Thank you very much.
Thank you. So, we have some time for questions. Is there a microphone? Okay, microphone back. Anyone who wants to address one of the topics discussed here? Yeah.
Thank you. That was some great talks. It's Shelley Vick. I'm from Alberta Health Services in Canada. So I have questions for a couple of you. Dr. Kazimaki, I'm sorry if I didn't pronounce that right. In your model that you put up with that chart, I took a picture. It was quite interesting. It looks like you have one overarching management authority, and underneath that you had all your services, including primary care. I'm just curious, does that include your primary care physicians report up to this authority as well?
Yes, so it's in Finland, particularly in the public health services, the physicians are salaried employees, so just like other professional groups. So they are really in the organizations. They are not just consulting the other professionals. So that's
wonderful. So it brings you a lot closer to that integration step. Yeah,
yes.
Fascinating. Thank you. And then I had a question for the clinicians from Toronto. You had mentioned about your physician database, and you said you were having trouble with getting access to that. I guess two questions, maybe, depending on what the answer is to the first one. When you said physician database, do you mean a database of the physicians, who they are, where they are, their gender, how long they've been practicing? Yes, is that what you're referring to?
And whether or not they're doing comprehensive primary care.
Oh, okay. So that's
and where their practice is.
Where? Because in Alberta, our College of Physicians has almost all of that, except the last piece.
Yes, we do too, but they wouldn't share it for privacy reasons.
Your college wouldn't share it?
Yes, that's correct.
Okay, thank you.
Yeah. To the right, to your left. Okay, yeah, thank you.
Hi, Nicholas Hicks from Optometrics Clinic in the UK. It's just a quick question. I was just reading the strapline of the conference, evaluating and implementing models of integrated people-centred services. And each of you have described some quite significant service change. My question was, did any of you involve patients and citizens? And if so, what difference did it make?
We did. We have a citizens advisory panel, both at the regional level and at the local level. And so many of our initiatives we brought to the citizens panel for input, and we actually revised our strategies based on their input.
That's for Toronto.
How it changed, how the involvement changed what you thought.
So I'll just give you one example. We were planning to have a patient survey of the discharge summary process. So we had the patients write the discharge summary questionnaire to patients. What was important to them in the discharge summary process, and we're just piloting that to roll it out. We developed a coordinated care plan, and many patients were involved in what that looked like. So we try to bring as many things as possible to them.
Yeah, I don't know, some complementary answer?
We didn't really. We didn't have a choice.
You didn't have the choice, yeah.
But we did explain to them what we were doing and why. So, yeah. But we didn't have the luxury of planning it a long time in advance.
Okay, yeah. Any other question? Yes.
Hi, thank you. Sarah Thomas, Public Health Wales. Thank you everybody for some really interesting presentations. My question really relates to the last presentation, colleague from Poland. In terms of the uptake of the check that you were offering, I didn't quite get from the slide what level of uptake you were getting, percentage of people who were invited to attended. And in response to that, have you looked at uptake according to deprivation? So are there differences in the level of uptake across deprivation?
I'm not sure that I understand you correctly.
So the first part of the question is the level of uptake.
Uptake
of the proposed checkups.
But so of the people invited, are you getting many people taking up the offer, so coming for the check?
Now, still I'm not sure that I understand your question, because you ask about the uptakes.
Uptake, which means it's offering. There is an offering of a checkup to the people. To what percentage do people effectively have the checkup?
Okay, so we say that the limit for the active checkups should be 30% of this population. 30. 30. But I showed that 300,000 people are covered, but not all of them are the participant of the checkups, because checkups are from the patient between 20 and 65 years old. So the third percent from this group.
But is it going in the sense that you are reaching the 30% objective?
We would like to achieve this limit, but we are not sure that it's possible because at the beginning the project was for 2 years. So half a year we need for not only we but the providers need time to learn how to organize the practice, how to invite the patients for the checkups. Especially the biggest problem was how to convince patients to come second or third time for the especially educational visits, because patients want to prescription and referral and go. But now when we have the extension of the project, I think this is the chance to achieve this 30%.
So, wait and see and have the follow. Yes? It's okay, you can use it, yeah.
I give some answer as a provider of this project, because my center do this project. So it's, you know, this is something new in our system to invite the patient for the checkups. It still have the scientific board have some not very sure about this method, but our centers are quite divided. Some of them are quite well prepared, so they made before some inviting people for the prophylaxis. They can manage better than this who start on the beginning. So nowadays we have probably some of them are about 10–15% of the population is invited, and some of them more than 30–35% now. Okay.
Okay, thank you. Any other question? No. I think we are getting a bit tired, but this was I find it a very interesting panel, and would like to thank you very much for your contributions, and thank you for attending here. Enjoy the drinks, and see you back tomorrow. So give them an applause.